You are audible. Yes. Yes. Yeah, that's good. That's good. And we can hear, can you hear us well as well?
Yeah, I can hear you both talking.
Okay, so if all of us keep muted at the time when we get the time to respond, that will be fine. But that was a good sound check. Yes, thank you.
All right.
Okay, so it's 13:30, so 6 p.m. Kashmir, I take it, right? Should we start?
Yes.
Yeah, you can click the live button.
Okay, assalamu alaikum everyone. Good afternoon, good evening to people in Kashmir and also here in the UK. And thanks for joining us in this interesting webinar on respiratory support workshop with NIV context. My name is Dr. Saeed Imtaz Gilani. I'm a consultant in emergency medicine in southeast of England. This is the East Kent Hospital, which is one of the biggest hospitals in the country, the 5th biggest in the country. I'm also been director for clinical in emergency and acute medicine previously. And thank you for joining in. I know it's Sunday and it's evening time in Kashmir, so thank you very much. Before I kind of start introducing the agenda and the speakers and my panel, a few housekeeping issues so that we have a smooth running of this Zoom session. First of all, I'll be grateful if people could keep their microphones on mute. No, the admins can do that anyways, just in case of any glitches. I would be grateful if you could keep your microphones on mute. There's a chat box open, which will be monitored actively. So if you have any queries, which I would be greatly grateful that you do that, so that we have an interactive session, because the last thing we want to do is hear didactic lectures. I want people to interact, ask questions, and we'll hopefully answer them real time, or I might throw them back to the panel and our speakers to respond as they come. So, the other thing which we're going to do is we'll be very grateful for your feedback, and the way we're going to do that is by sharing a link towards the later part of the presentation. And once you click on that, there'll be a series of 5 questions, very simple, and we'd like your email address so that we can send you a certificate of attendance. So there's a interest for all of you to give us that feedback. So that'd be fantastic. So at the very outset, before I make any starts, I would like to say a huge thank you to the Director of Health, Dr. Mustaq Rathar, for his collaboration and for making this happen. Also, a huge thank you to Professor Samir Rashid, Principal GMC in Associated Hospitals. And I'm also grateful to Dr. Manzoor Qadri from Director of Health, who played a huge part in making this program come to fruition. So thank you very much. And also a huge thank you to all the attendees for taking part in this workshop. Before I proceed any further, let me introduce our key speakers and the panel. So I'm really pleased that I have my colleague, Steve Jenner, who is a critical care nurse, has been doing that in my trust, in my hospital for the last 25 years, and is an expert on non-invasive ventilation in both non-COVID settings, and of late, he has a lot of experience in COVID patients also. I can say with assurance, there's something about NIV he doesn't know, it's not worth knowing. Steve, is that right? He's going to come in a second.
So you say, yeah.
Thank you.
Yeah.
And he has come off a series of night shifts, so very grateful for that. He still took the trouble to come to this after a night shift. And then in the panel, we have Professor Ruxana Najib. She is the HOD of anesthetics and critical care at SMHS and Associated Hospitals. So thank you, ma'am, for joining in. And we'll be listening to her presentation later or in the panel discussion. We also have Dr. Zulfikar Ali. He is an ex-colleague of mine, a classmate from my school days, who is a critical care and neuroanesthetic consultant at Skims Hospital, Kashmir. We also have. Can you mute the microphones, please? Thank you. Zarka?
Yes, I'm doing that.
Thank you. And we have Dr. Mohammed Omid, who is a consultant in.
Thank you, Dr. Imtiaz.
Imtiaz, you are muted. Can you unmute yourself, please?
Okay, I will go back. So we have Dr. Mohammed Omid, who is a consultant anesthetics at and critical care at SMHS. And we have Dr. Yasser Rashid, who is a friend, a colleague, who is a consultant in the Oxford area of UK, and who has been absolutely instrumental in making this program. So thank you, Yasser. He's in the panel. And we also have Dr. Saika, who's a consultant anesthetics in Director Health. Unfortunately, because of a family emergency, she could not make it today. Right, so that's the panel, and I'm very grateful for the panel. So the agenda for the day is we're going to start with the workshop. Previously, we did a webinar on the theory bit of NIV in COVID, etc. But this is more about the practical bits, how to do it, the pitfalls, the pearls, which we can learn from Steve. He does this day in and day out, and also how to do it safely, the governance around it, and how to have those treatment failure plans when things don't go to plan, escalation plans, and when to failure and so forth. And also a bit about safety, about how to keep your staff safe, because as we know, these are AGPs, aerosol generating procedures. And then we will have a panel discussion, and there are a couple of presentations from Professor Roxana and Dr. Yasser and Dr. Zulfikar Ali, and very keen to listen to them. And in fact, throughout the program, I would be grateful if people could post their queries, and so that we can kind of come back to those in real time. So that's it. So a brief backdrop. So we all know what's going on with the pandemic and the challenges it presents to not only as a clinical onslaught, the onslaught on logistics, your resources, as we don't always have the ideal option for each patient, and that's why we have to talk about other modalities. And we did play a crucial role in how we manage COVID, and did help us. So I don't want to hold your next speaker any longer. So a huge welcome to Steve Jenner, and he's going to talk about his experiences, and he has a couple of presentations. Right, so thank you, everyone. Thank you, Steve.
Hi, so just a bit of background about myself. So I'm Steve, I'm one of the critical care outreach senior charge nurses here, working with in the same hospital for the same trust as Dr. Gilani. I've been in my current post for 10 years, have 20 years experience of caring for and helping support medical and nursing staff patients on non-invasive ventilation and other forms of respiratory support, and have been teaching and training around the same subject for approximately the last 10 years to both nursing staff and medical staff. In terms of recent experiences, we had our second wave from approximately November, end of November through till April. On this site at the William Harvey in Ashford, we have 16 intensive care beds. During the second wave, that capacity was ramped up to 24 intensive care beds. Outside of that, on the site, we had anywhere between 30 to 50 patients in other clinical areas, i.e. wards, on respiratory support, such as Optiflow or CPAP or NIV, IPAP. So the team that I work in, there's 8 of us. We support intensive care out of intensive care. So we focus on ward areas with patients that are highly acutely unwell, needing potentially intensive care support or just stepped out of intensive care. There's quite often only one of us on shift at any given time. So as you can imagine, with 30 to 50 patients with COVID on respiratory support on the wards during that period, we had huge amounts of exposure and experience that we gained over that period of time. So I'm just going to start with a brief presentation on Optiflow or high flow nasal oxygen. Is that?
Yeah, sure. The second?
Yeah.
Just going to share the presentation in a sec. So, okay, Yasser, can we see the presentation?
Yes, I can.
Thanks.
Yeah.
Just going to put this in running mode.
Okay, so sorry, I'm trying to get myself in camera shot because I'm 6'4" and I'm not taller than size.
Are you tall? I need to cut you down to size, Steve.
So I'm conscious that some of the equipment that you're using in Kashmir is different to the equipment that we use in Kent and in the UK. However, as I've explained to Saeed, the principles around how it works and why it works are very similar. So excuse me if you're not familiar with the actual equipment per se that I'm talking about. However, the principles I'll try and stick to the same. And in terms of the session I'll be doing next on non-invasive ventilation, I've tried to do a little bit of internet research about some of the more common equipment or machines that it's been fed back to me that you're using. So in terms of high flow nasal oxygen, okay, the machines that we use in East Kent are Airvo 2 machines. Okay, they're manufactured by Fisher and Paykel. Some of the pictures I've been sent from some of you guys, it looks like you're using similar sorts of devices for high flow nasal oxygen. So hopefully this is a very brief presentation. The principles are all exactly the same. There we go. I'm on the wrong keyboard. Sorry. Okay, so obviously it's driven by nasal cannula. Okay, it has several modes of function that have a positive impact on the patient's therapy and recovery. Okay, one of the primary modes is it provides a washout of what we call the anatomical dead space. Okay, so the high flow rates up to 60 litres a minute help keep the anatomical dead space full of oxygen-rich air for each inspiratory phase of the breath cycle. That's just a quick diagram of the oxygen components of atmospheric air on the left and the oxygen component of our dead space air. Okay, so if you think when we expire, the first sort of 150 mils of each breath that we take in is dead space air. Okay, and that's very oxygen poor air. So if we've got patients that are acutely unwell for respiratory problems that have got very reduced tidal volumes down to sort of 200, 300 mils, the first half of that volume of air that they're taking in is oxygen poor. Okay, so what the Optiflow does is it ensures that we maximize their volume of air breathed in so that that's oxygen rich. Okay, so how does Airvo benefit our patients? Okay, or high flow nasal oxygen? It eliminates the anatomical dead space, as we said. Okay, it's humidified, it's heated. Okay, and at its optimum temperature setting of 37 degrees, it will provide 95% humidity. Okay, we have 3 temperature settings on the machines that we use: 31 degrees, 34 degrees, 37 degrees. 31 degrees should only be ever used if we're delivering it via a face mask. Okay, and acutely there's no real benefit to that. So we would normally set ours at 37 degrees, and dependent on patient tolerance and comfort, we might drop that temperature down to 34 degrees. It provides patients with a more comfortable and tolerable option for respiratory support therapy. Okay, so when we think of this in the context of our other main form of respiratory support for hypoxic respiratory failure, which would be CPAP, The comparisons are very clear as to why high flow nasal oxygen would be much more comfortable, much better tolerated by our patients. It's delivered via small, so I don't know if you guys can see here, so very small, very soft nasal cannula, okay? And they're very comfortable for the patients to wear.
So can I ask you a question here? Are there different sizes of that nasal cannula depending on patient habitus, or is it one size fits all?
So the different sizes are, so the equipment we use comes small, medium, large, okay? The guidelines from the manufacturers are the nostril, each nasal cannula should consume about 50% of the patient's nostril, okay? That's the guides that we're given. So it is a quick visual inspection of your patient's nostrils, and then an inspection of the different sizes of the cannula that we use to see which size you think is going to be best suited for your patient. Okay. That said, on a very important point on that, if you are trying to deliver the higher maximal flow rates, i.e. 50 to 60 litres per minute, the machine does struggle trying to deliver that through the smallest size nasal cannula. Okay, so sometimes even if it fills more of the nostril than approximately 50%, if you're delivering higher flow rates, it is better to use a slightly larger size nasal cannula. Because of the humidity, it will optimize mucociliary clearance. Okay, so for patients that have got nasty pneumonias, all those sorts of things, it will help optimize them and put them in a good state ready for chest physio. It will deliver a small amount of positive pressure. Okay, so it has a small PEEP effect. The diagram that's on the right of that slide, the optimal PEEP effect it will provide is if your patient has got their mouth closed during therapy. Okay, we've said that we deliver this via nasal cannula. Obviously, if you've got patients that are mouth breathers, a quantity of that flow is going to be driven straight back out of their oral opening. Okay, so this is very good for patients that are very compliant and understand that the best effects from it will come if they keep their mouth closed during therapy, obviously with the exception of times for eating, drinking, conversation. Okay, delivered at about 60, delivered at maximum setting of 60 litres per minute in a patient with their mouth closed, it will have a PEEP effect of about 6 centimetres of water. Okay. Obviously, the higher flow rates, the more PEEP effect that it's going to have. It also enables us to give a broad range of therapy for our patients. Okay, so we can deliver flow rates of anything from 10 litres a minute up to 60 litres a minute, and oxygen concentrations of anything from 21% up to approximately 95%. Okay, and both of those parameters are individually changeable. Okay, so it gives us a big range of therapy for our patients. And also, when you think about it in comparison to CPAP, it provides a much better therapy for patients to eat, to drink, to talk, and to sleep. Okay, much more comfortable, much better tolerated. Okay, there's also not many contraindications with high flow nasal oxygen. Okay, so the primary ones are we would commonly use this for patients in a type 1 or hypoxic respiratory failure. Okay, we wouldn't use it for patients in a hypercapnic respiratory failure because of the concerns of being cautious about the quantities of oxygen that we're delivering. Patients with basal skull fractures or any facial trauma or recent facial surgery, and also epistaxis. Okay.
Steve, a couple of questions here. One is, which obviously you know about, happened here also in the UK, is sorry, there's some background noise there, okay? The implications on your oxygen supplies and pressures. If you have 10 or 20 patients, this is something the feedback from my colleagues in Kashmir also found here also is, you know, what's your experience being with regards to the use of these machines and the impact on the oxygen supplies?
Yeah, so they do use more of your oxygen supply, high flow nasal oxygen, than a CPAP or BiPAP, okay, equivalent. That's a given. Okay, we were fortunate enough to have a new oxygen during the first wave, for us during the first wave, that was a very real issue. And in fact, during the first wave of COVID that we had last year, we actually didn't use high flow nasal oxygen at all on any of our COVID patients for that concern that it used a vast amount of oxygen. Okay. However, in the second wave, we were in a better position and we were able to then use it on some of our patients. In terms of where, so we've talked about type 1 hypoxic respiratory failure, so pneumonias, chest infections, pleural effusions, all these sorts of things. Okay, where is its place in COVID? The jury's out, okay, as it is with a lot of things with COVID. There's still a lot of people collecting a lot of data, doing a lot of research. Okay, from experience, its place in COVID is absolutely for your patients that are on non-invasive ventilation. They tend to be very dependent on that support. Okay, so to provide them opportunities to have breaks for nutrition and fluids, Optiflow or high flow nasal oxygen, that's absolutely essential. Okay, because it will allow you to step your patient off of their non-invasive ventilation, still onto quite significant respiratory support for enough time for them to take some food and fluids on board. Okay, a little break if they need it off the non-invasive ventilation, and then back on after they've had a small break, a small amount to eat and drink if they can tolerate it. Okay. The other places for it are if your patients are non-compliant or intolerant of non-invasive ventilation. Okay, it gives you a second option of, again, still quite significant respiratory and oxygen support for your patients. And also for patients that we're weaning from non-invasive ventilation. Okay, those patients with COVID will struggle to come straight off non-invasive ventilation. Okay, so most of these patients we would wean off of their non-invasive ventilation using high flow nasal cannula or high flow nasal oxygen. In terms of the risks, initially sort of pre-COVID and during the first wave, there were a lot of concerns in terms of, obviously it's an aerosol generating procedure and it's used patient interface with nasal cannula with high flow rates. There was a lot of concerns about the risk to healthcare professionals and their exposure of aerosol droplets in comparison to CPAP, where the masks and patient interfaces are kind of a lot closer, a lot close circuit. Actually, what I've read is, or what has been discussed is actually there tends not to be much more aerosol generating from Optiflow as there is with CPAP or non-invasive ventilation. Okay, as long as you make sure that your patient is wearing it. What you don't want is for them to be taking it off and have nasal cannula just hanging in the air with high flows of oxygen releasing droplets everywhere. Okay, in terms of PPE, again, it is an AGP, as with CPAP and as with BiPAP during COVID. All of our patients that are on high flow nasal oxygen or non-invasive ventilation, we manage with full PPE, so full length gown, gloves, visor, FFP2 or FFP3 face masks.
Steve, would you say you have to have a negative pressure room for HFNOs, or because that's not always possible?
So ideally, we would we would isolate our patients in their own room with negative pressure or other forms of ventilation, i.e. open windows. As I discussed at the start of my talk, during the second wave, where we had huge amounts of patients in clinical areas on aerosol generating procedures, what we did was we cohorted those patients. So any patients on AGPs, we would cohort into 4 or 6 bed bays. Okay, and we had those bays and those wards adapted to be negative pressure and have ventilation as well. So we tried to, if we couldn't provide an isolation single room, cohort them into bays of patients all on aerosol generating procedures.
So that might work, obviously, when the warning pressure is high. A couple of practical things. Would you always use sterile water for the humidification chamber, or because I heard people inadvertently using saline and it crystallizes and all that?
Yeah, we would only ever use sterile water. Okay, manufacturer's guidelines is sterile water, not sodium chloride.
Absolutely. Yeah. And lastly, is there any risk of the oxygen levels being too high because of contamination, risk of fire, etc. Because we saw some ITUs go on fire in India. I don't know whether this was a part to play or not, but do we monitor the atmospheric oxygen levels like we heard in the last webinar?
As far as I'm aware, we haven't been on site here measuring atmospheric oxygen levels within the hospital in the bays.
Yeah.
However, as I said before, you would want your patients to be wearing this most of the time, and not to have the nasal cannula hanging with the flow rates driving just into the atmosphere. Sure. Okay. For that reason, but also for the risk of aerosol generation and potential contamination to other patients or healthcare workers. Okay. In terms of the machines we use, just quickly, the disposable, so the circuit, the water chamber, the tubing, the nasal cannula. Okay, they're all, we change those after 7 days. Okay, so 7 days, a patient, if they're still requiring the therapy, will get a fresh set of disposables. Okay, and we also have a decontamination circuit. Okay, so when it's finished with one patient, it has the high temperature decontamination circuit that connects up, and it runs through an hour's decontamination process, as well as there is a filter at the back of an air filter at the back of our machines, okay, which gets changed for, I think it's every 1,000 hours use, but we have a little reminder message that pops up on our display screen of our machines that we use.
Steve, happy to take a couple of queries from the chat box. So,
yeah.
Yasser, can you read out the questions to Steve, please?
Yeah, sorry. So there was a question about, is there an aspiration risk, which I have partially answered, but could you put some info into that?
Is that an aspiration risk in the context of the humidity of the treatment, or if they're taking food or fluids at the same time as having the treatment?
Well, I don't know exactly what they meant, but they meant, is there a risk of aspiration while we're using high flow nasal oxygen? I have replied that partially, saying that we screen the patients, and those who are at high risk, for example, bowel obstruction or low GCS, they may be at high risk. But other than that, if you have screened the patients, usually the risk is not that high.
Sure.
Yeah, I think what you're saying is absolutely correct. I mean, we wouldn't advocate using it on patients with a low GCS or patients that are having particular difficulties with swallowing or aspiration risk generally anyway. Outside of that, really, there shouldn't be any real risks in terms of aspiration.
Thank you, Yasser.
There's one more question just popped up, which says, what is the effect of open versus closed mouth on HFNC? Which I think you did mention a bit of physiology related to that, Steve, earlier, that you may lose some airflow through the mouth.
Yeah, so just for clarity on that, obviously the PEEP effect is going to be much more effective in patients with mouth closed. Okay, this is when we're saying what patients would you use it on? Patients that are compliant and understanding that to get the best effect to keep mouth closed, they'd be prime patients to use it on. Okay, so a PEEP effect of approximately 6 centimeters of water at 60 liters of flow with a mouth closed. Okay, mouth open, that PEEP at 60 liters a minute, that PEEP effect drops to about 3 centimeters of water. So there is quite a significant difference. And just also quickly, I forgot to mention the other question we often get asked is, what settings do we use? What ranges do we use when we're starting patients on the therapy? Okay, we don't have many of these machines on site here. In fact, I think we only have 12 to 15 on site here. So we were very selective during COVID as to who and when we used them. In terms of how do we use them, what pressure set, what flow rates, and how much oxygen, it's very much feeling about what's your patient's requirement, okay? Because we use them acutely for acute therapy and hypoxic respiratory failure, we advise to start with flow rates as high as your patient can tolerate, okay? So if your patients are able to tolerate 60 liters of flow a minute, okay, and mouth closed, we advocate that, okay? The more flow, the better PEEP effect, okay? The better their therapy is going to be, the more effective, okay? And if they're unable to tolerate flow rates of 60 liters a minute, what I would then generally do is reduce the flow rates at 5 to 10 litre per minute intervals Check in with your patient. Is that comfortable? Can you cope with that? If they're able to, stop where you are. If they're not, wean down further. Okay. At flow rates of less than 30 litres a minute, for patients that are acutely unwell, there's probably no real benefit to high flow nasal oxygen apart from the humidity that it provides. Okay. Outside of that, flow rates of less than 30 litres a minute acutely are not going to provide a massive benefit for your patients, especially if they're mouth breathers. Okay. And in terms of oxygen concentrations, how much do we give? Okay. As with any forms of oxygen delivery, we give our patients as much as they need to maintain their saturations at whatever their target saturations are. Okay. Bearing in mind with your high flow nasal oxygen, your flow rate acts as a dilutant. Okay. So if you've got your oxygen set at 60% and you increase the flow rate, your oxygen concentration is going to dilute and reduce. Okay, so if you're adjusting your flow rate on high flow nasal oxygen, you will also need to readjust your oxygen setting as well. Whatever your device uses to control the oxygen concentration, you will need to also adjust that if you're adjusting your flow rate.
Okay, Yasser, any other
Can I-
questions?
Yeah, I have a few more questions. Actually, I missed one question, which was asked by Dr. Sajjad Hussain earlier. How is patient tolerability and effect on nasal mucosa as compared to the conventional nasal cannula oxygen delivery? So these are two different devices, but I will let Steve speak about it first.
Yeah, they are two different devices. It is, sounds like I'm passing the buck a little bit. It is really dependent on each individual patient. Okay, so traditional nasal cannula, the traditional nasal cannula that we use in our trust, we can only deliver flow rates of up to 6 litres a minute, okay, which will only give oxygen concentrations of about 40% FiO2, okay. Some patients, if that's all the oxygen they need, and are absolutely fine and comfortable with that. Some patients find that quite dry. They find it dries out their nasal passage. They don't find it very comfortable, okay. In terms of high flow nasal oxygen, firstly, it allows us to give much higher concentrations of oxygen. Secondly, it enables us to give much higher flow rates. Okay, so it will, if patients can mouth closed breathe, give a little bit of a PEEP effect. But also some patients, as the question asked, some patients can't tolerate with the amount of moisture that it generates within the upper airways or mouth and nose. Okay, so it does sometimes cause a lot of, if you like, nose dripping, and patients sometimes aren't comfortable with that. As I'll talk about with non-invasive ventilation, what's key to these things that we're using is that we explain how they work and why they work to our patients. Okay, so if we prepare patients for what might happen, they tend to cope with things much better. Okay, so I would normally always say to the patient, you might find it quite warm. Okay, there's not really an awful lot. Even dropping the temperature from 37 to 34 doesn't actually have a significant effect in the heat of the therapy, just a small amount. I will also tell them it might cause you a little bit of nose dripping. Have tissues handy if you want. Okay, it shouldn't be an issue. The benefits of the treatment, you know, are actually, for me, outweigh potentially the discomfort of the issues in terms of the moisture. Okay, but obviously it's patient dependent. If they can't cope with that, then we find other means of trying to organise their oxygen therapy.
Thank you, Steve. I think I'll just, for the sake of time, move on to
Yeah.
the bigger presentation. I think the take-home message, yes, Yasser?
One quick, I
Yeah.
want to add to it. These are two different devices, as I mentioned earlier. The Airvo is a specialized device with humidification mechanism. So it does help the mucosa in terms of not damaging it as compared to high flow oxygen through the nasal cannula. So this equipment is quite safe and better tolerable than the simple nasal cannula. As Steve mentioned, maximum rate is only 6 liters. There's one more question, that how does the central supply pressure affect? It is not the supply pressure, it's the amount of volume, it's the liters per minute. So as long as you can gather that much oxygen to give this much liters, up to 60 liters, that is fine. And one question for you, Steve, which I would pass it on to you, which I know I don't, there's no point doing that, but I want you to say that. Can we add polymask on HFNC to increase flow rate? I don't think that, but
Can we add?
polymask or a simple face mask of some sort on the high flow nasal cannula to increase flow rate. It's the high flow through the cannula, I guess. I don't think any other device will change it.
I don't think there would be any benefit in doing that. The reason that I say that is because with the high flow nasal oxygen, we can deliver 95% oxygen and flow rates of 60 litres. Okay, so I think if you're thinking your patient needs additional oxygen or additional support in terms of flow or pressure, and they're already on higher levels of high flow nasal oxygen, but probably then or before then is the decision about is it appropriate for them to be considered for intubation and ventilation. Okay, I think adding an additional face mask over the top I don't think it will add anything of any benefit for your patient, and B, probably we need to be thinking about forms of escalation of treatment.
I've seen a few pictures of our patients who are on HFNC, and on top they had not even bags. I don't think that's really going to be.
No, one exception to that would be when we're delivering medicated nebulizers, we will quite often put medicated nebulizers through a chamber and a face mask over the top of the nasal cannula in high flow nasal oxygen. That's really the only exception that we do that.
Just want to add last question. It's clear from all this that we have, when we're using high flow nasal cannulas as an airway devices, you don't need to use any other device with it. There's one question about whether we need to do heat sterilization and how frequently we need to do that. Do we do heat sterilization?
For the circuit, do you mean? Is that?
Well, circuits, I wouldn't do heat sterilization, but I don't know how it works. But
no, I think if it's staying with the same patient, we wouldn't do sterilization of the circuit. Okay, I don't know what the context in that is. Our disposable circuits, i.e. the tube in the nasal cannula, the water chambers, a single patient use. Okay, so when the patient has finished their therapy, all of the disposables go into the bin, okay, and the next patient, the machine, we then give a wipe over with antiseptic wipes. We put the decontamination heated tubing on and put it through a decontamination cycle, okay, and it then goes into equipment storage and comes out, and the next patient that uses it gets a fresh set of disposables.
But in Kashmir, you may have to use the circuit over and over again. I remember my times when I was working in ICU there, it was a different, I mean, I'm talking about 10, 11 years ago. We used to put the ventilator tubings in 2% glyceraldehyde and then dry it up, Sidex, but I don't know what's done now. So that's
I mean, it's a different situation. Obviously, I appreciate the fact that things are probably a lot more challenging for you in Kashmir. What I would advise is that you get manufacturer advice in terms of if their disposables are, if you can reuse them, and if it's possible to sterilize them in between patient use.
We have many queries about when do we start, but I will talk that in
the. We can take on the panel because
that's all in the panel. Yeah, that will come.
So the take-home message is talk to patients, tell them what's coming, because it's like you're hitting them with the high flow O2, which is hot.
Yeah.
So it's very important to counsel the patient what's coming. I think spending those couple of minutes before we start might save a lot of grief later on. Okay, Steve, thank you. So on to your next presentation, which is really exciting, I know. So, you want to do something? You want to do?
No, I'm just going to move this out right now.
Yasser, can you see the next presentation?
Yeah. You want me to share it?
Yeah, it's already shared, is it not? I thought it was shared.
It is non-invasive ventilation.
Yeah. Okay. Cool. Sorry, it's on there. Okay. So now we'll talk a little bit about non-invasive ventilation. Okay, in terms of how and when we use the different modes, CPAP, BiPAP, what sort of settings we use, okay, here in East Kent, and monitoring care of our patients, okay, some pitfalls. I'm happy to answer some questions. The take-home message for non-invasive ventilation is, again, with high flow nasal oxygen, please always explain to our patients what we're doing to them, okay? From experience, one of the main causes of NIV failure is due to patient non-compliance or patient intolerance, okay? One of the main causes of patient non-compliance or patient intolerance is us, okay? And it's us as users of the equipment, okay? And the main reasons for that are we've selected the wrong patient interface, i.e. mask. We've got the fit of the patient interface wrong or incorrect. We've selected the wrong settings on the machine, or we haven't checked and altered patient comfort settings on the machines. Okay, so one of the main causes of treatment failure for non-invasive is actually, as healthcare professionals, what we're doing or not doing correctly with the therapy. Okay, so that's the key. Also, we haven't explained it properly to our patients. Okay, and if we explain things properly to our patients, so they understand what to expect and how things are going to feel and what's going to be happening, again with high flow nasal oxygen, they will tend to comply and tolerate treatments much more effectively. Okay. So what we're going to cover is what non-invasive ventilation is, things we think about before we start it, the differences between CPAP and BiPAP and the settings that we use. When I say nursing care, I mean care of our patient, okay? It's not just nursing staff that are responsible for the care of our patients, it's all allied care professionals. Some of the main contraindications, and when we think about stopping therapy, okay? Again, I appreciate the machines that we use here are going to be different to the machines that you guys are using in Kashmir. The principles will be the same. I've had some photos sent to me of some of the machines that you're using, and I've tried to kind of include what appear to be probably two of the more common ones that you're using in Kashmir currently. Okay.
These ResMed, is it?
Yeah, so it seems like there's quite a lot of use of ResMed Air Curve or something similar, and also Respironics BiPAP AVATS machine is a lot of the pictures that I've been getting sent through. So obviously non-invasive ventilation is provision of ventilatory support through the patient upper airways using a mask. Okay, or nasal cannula. Quite often patients on home therapy will use nasal face mask devices, and it comes in two modes: CPAP and BiPAP. Again, another key message is if the patient needs intubation, they should be intubated. Okay, we should not be using non-invasive ventilation as a bridging measure or a holding therapy for patients that need to be intubated. If they need to be intubated, that is what should happen as soon as is reasonably possible. Okay, so just some of the indications for intubation. Okay, to protect airway and facial trauma, burns, loss of consciousness, treat profound hypoxia, so PaO2s of less than 8 on concentration of oxygen of sort of greater than 60%, routine post-operative care, allow to aid removal of secretions in patients with muscle wasting disorders, rest in patients that become exhausted. Okay, so commonly asthmatics, definitely COVID. Okay, we'll talk about COVID, and what I'll try and do is talk about when and what settings we would generally, outside of COVID, we would use, and then what settings we would use specific to COVID, because there are some differences. Okay, and also patients with cardiovascular instability that aren't going to be able to cope with the issues caused by positive pressure, non-invasive positive pressure ventilation. So what are the benefits of non-invasive ventilation? So primarily it reduces the incidence and complications associated with intubation and mechanical ventilation. Okay, some of those are reduced cardiac output, nosocomial or hospital or ventilatory acquired pneumonia, tension pneumothorax potentially, airway and laryngeal trauma, and bronchospasm. It will also reduce length of hospital stay for our patients. If we can get them through on non-invasive ventilation, a length of stay generally is going to be far less in hospital than if they end up intubated and mechanically ventilated. it will reduce admissions to ITU. Okay, we saw the most obvious time that we saw this was during COVID. Okay, when our intensive care capacity was nowhere near enough that we needed at the time. It will also reduce morbidity and mortality. Okay, so chronically ill patients are not put through lengthy intensive care admissions. So with this, I mean when we're using BiPAP on some of our chronic lung disease patients, okay, there we can normally get them through their acute illness on non-invasive ventilation. And also it will buy time. So while we said we don't use it to buy time to intubation, we do use it to buy time for conventional medical treatments to work. So antibiotics, steroids, diuretics, all of those sorts of things. What we're trying to treat is underlying cause. Non-invasive ventilation will help support the patient through this phase while the medical treatments are starting to have their effect. So CPAP, we talked about CPAP, BiPAP. CPAP is continuous positive airway pressure, okay? The air flows continuously into the airway and acts as a splint, applies positive pressure at the end of each expiration, okay? And that's the key message. With CPAP, all we really need is that positive pressure right at the very end of each expiratory phase to keep the alveoli open, nice and full with oxygen-rich air to transfer into the circulation. And initially started out and remains a key treatment and therapy for patients with sleep apnea. So how does it work, CPAP? So during normal unassisted respiration, we generate a negative pressure within our airways to draw air in. Okay, with CPAP, it creates and maintains a positive pressure in the upper airways and the lower airways. They're splintered open, air's forced in, oxygen rich, and it will help also oxygenation, but also reduce the work and effort of our patient's own respiratory drive. So this is a diagram of how CPAP works with patients with sleep apnea. Okay, so what the positive pressure does, it just helps shunt the soft tissue from compressing their airway. That's a chest X-ray of a patient that's receiving CPAP, which just shows nice hyper-expanded lungs, okay, nice clear bases of their lungs. What does it feel like? Okay, so I'll always ask, have you ever tried to have you ever worn CPAP? Okay, key number one, okay, is if you haven't tried it, you won't know what it feels like, okay, and it's not pleasant. I've tried it. It feels a little bit, I like this slide because it's got a dog in it and I love dogs. So it does feel a little bit like if you're in a car speeding down the highway or motorway and you choose to pop your head out of the window and you try and take a breath in, that's what it feels like. You just get this overwhelming sense of air being shoved down. Okay, it's quite uncomfortable. Okay. It also feels like when you're on a fairground ride and you can't exhale. Okay, so it causes issues with that feeling of not being able to expire properly. So in the context of, we've said it can be quite uncomfortable, how does it help our patients? Okay, it helps reduce worker breathing. It will inflate any collapsed alveoli and keep them open. Okay, it will recruit areas of collapsed lung. Okay, so it will increase surface area and it will prevent any further alveolar collapse. So one of the common reasons outside of COVID that we would use CPAP is in patients with pulmonary edema. Okay, so patients with LVF, pulmonary edema. Okay, what CPAP does there is it has like a sponge effect and it will help squeeze that fluid from the lungs back out into the pulmonary circulation. So in summary, CPAP improves alveolar gas exchange, increases surface area. It will improve oxygenation without the need to increase oxygen delivered. And actually, quite often these patients, especially with pulmonary edema, that will commonly be on 15 litres non-rebreathe, approximately 80–90% oxygen. When we put them onto CPAP, we can quite often wean their oxygen concentration down quite significantly. Okay, and it will increase lung volume and functional residual capacity. So we talked about indications for CPAP. So type 1 hypoxic respiratory failure or respiratory distress, sleep apnea, LVF, heart failure, pulmonary edema, okay, pneumonia. This is a bone of contention. Okay, so patients with pneumonia tend to have quite poor outcomes if they end up on CPAP. Okay, the caveat to this is if it's their ceiling of care, and when we talk about ceiling of care, I mean they're not appropriate or not a candidate for intubation and ventilation, we would use CPAP if the patient really needed it that's got pneumonia. Okay, and obviously why we're all here today, COVID pneumonitis. Okay, locally our trust guidelines in terms of when would we put our COVID patients onto CPAP, our guide is a patient that's got a PaO2 of less than 8 kilopascals on an oxygen concentration of greater than 40%. So settings. Now, when we're going to talk about settings, these are the settings that we would use for CPAP for non-COVID patients, pulmonary edema, potentially pneumonia, or other causes of hypoxic respiratory failure. So we would start with a PEEP, so positive end expiratory pressure of 5 centimeters of water, and we would look to increase this if we needed in increments of 1 to 2 centimeters of water, up to a maximum of a PEEP of 10 in ward areas. Okay, so what about generic ward areas with lots of patients? You know, not vast amounts of nursing staff. Pressures of more than 10 centimeters of water should ideally be monitored in level 2 areas, so i.e. CCU, HDU, resus, recovery, those sorts of areas. Okay. In terms of oxygen, what levels of oxygen would we give? Again, however much oxygen our patient requires to maintain their target saturations. Now, okay, some of you guys out there that are using the Respironics BiPAP AVAP machines, within CPAP mode, they have a patient comfort option that's called Flex. Okay, now Flex is optional. You can have it turned off, or you can have it set at 1, 2, or 3. 1, 2, or 3 is 1, 2, or 3 centimeters of water. What Flex does is it will drop the PEEP by whatever you've got it set at. Okay, so for example, if you have got your PEEP set at 10 and you have your Flex set at 3, the PEEP will be delivered at 7 until the very end of the patient's expiratory phase, when it will ramp up to 10. And then when your patient starts their inspiratory phase, it will drop down to 7 and then up to 10 and then down to 7 and up to 10. Why is this important? If you've got a patient that's struggling to tolerate high levels of PEEP, you can try to use a Flex option. Okay, it might make it a little bit more comfortable for them. Okay, and just out there, Flex is available in CPAP mode on most of the Respironic NIV devices. So there's lots of different Respironic devices. The one that we use here is called a Trilogy. We've got Flex on our machines as well. I've definitely Googled, and Respironics AVAP's BiPAP machine that some of you guys are using, it should be on there as well. So with CPAP, our use of CPAP in patients with COVID, okay, again, locally, our target saturations for patients with COVID are 90 to 92%, okay? A, because it's quite safe for patients to run on saturations at that level. B, because the COVID patients that we've experienced have horrendously high oxygen requirements, okay? And we had been, during the first wave, managing these patients on ridiculously high concentrations of oxygen for a very prolonged period of time, which can be a risk in itself. And B, that was B, sorry. So with COVID, our guidelines are, we would commence our CPAP, so a PEEP of 6 centimeters of water, okay? So when we've got our patient that's got a PaO2 of less than 8 on greater than 40% oxygen, we would consider commencing them on CPAP, okay? To start off with, a PEEP of 6 and an FiO2 of 60%, okay? If our patient is then meeting their target saturations, we would carry on with the treatment at 6 and 60% and repeat their blood gas after 30 to 60 minutes. Okay? If the patient, when we put them onto a PEEP of 6 to 60% of oxygen, is not meeting their target saturations, we increase the PEEP by increments of 1 centimetre of water until our patient has met their target saturations, okay? Up to a maximum in ward areas of 10 centimetres of water of PEEP, okay? If we then have a patient on a PEEP of 10 and 60% oxygen, and they are still not meeting their target saturations, we would then increase the FiO2 up to whatever amount we needed to meet their target saturations, okay? Bearing in mind, these patients are very sick, and at this level of support, if it's appropriate, we would have close communication with our intensive care colleagues here in this trust, okay? As it says at the bottom there, when we're up to those levels, we would be considering intubation if it's appropriate for our patients.
Stu, can I interrupt you here? So
Mm.
what's the maximum PEEP you're happy to go up to
So in
in an ICU
so
setting?
outside of level 2 areas,
Yeah.
we would say no more than 10, 12 at a push, okay? Just because the higher the PEEP, the more pressure, the higher the risks are to the patient.
The question I'm sure my colleagues from Kashmir will ask you, because the people they get are very sick.
Yeah.
People with saturated 75% and lower.
Mhm.
They can bleed, they have quite significant pneumonitis on the X-ray and so forth. And obviously, having the level 2 setting is not always available.
Yeah.
What all the risk of increasing the PEEP to any higher than 10 in a ward setting?
What are the risks?
Yes.
Your risks with higher PEEPs will be pneumothorax, essentially gas trapping, intolerance in terms of non-compliance. Obviously, the higher the PEEP, the more pressure, the more likely it is your patients are going to struggle with that level of therapy. Okay, so there's physical risks in terms of potential for increased risk of pneumothorax, increased risk of gas trapping, vomiting, gastric dissension, that sort of thing, but also increased risk of what goes with more pressure is more intolerance from your patients. Okay. Also, we can discuss proning. Okay, so awake proning's been quite commonplace in our intensive cares during COVID. Okay, a lot of their patients are proned, sedated, okay, intubated, ventilated. Awake proning, is more challenging. When we're talking to patients that are already feeling very breathless and we're asking them to awake lay on their front, they think we've gone a little bit crazy. Like, it's like, what are you asking me to do? B, it can be physically quite challenging on our patients that have got an increased body habitus. And C, it depends what you read as to how much evidence there is out there, okay, in terms of its benefit for our patients. Personally, I've seen it help some patients. I've seen it make no difference to some patients, okay? We do try to use awake proning in our patients on CPAP, okay, during COVID. And even during COVID, we were using awake proning on our patients that were on normal standard face mask oxygen. If they went up to 35% or above normal standard conventional oxygen, we would encourage them to awake prone as well, okay, with mixed results. The other issue with awake proning when they've gone on to CPAP is that can affect the fit of your patient interface device, so your mask, because quite often they're then having to have head to the side and it can distort the fit of the mask to their face. So sometimes you lose, sometimes it actually has a counter effect on the CPAP. So we'll move on to BiPAP. So bi-level positive airway pressure, okay. So with BiPAP, we have two pressures, one on inspiration that we call IPAP, one on expiration, which we call EPAP. So inspiratory positive airway pressure, expiratory positive airway pressure, okay. EPAP is the same as CPAP and the same as PEEP, okay. It's just a different kind of terminology for the same thing and same effect, okay. On the machines that we use, so our Respironics trilogies, on the machines that I've seen you commonly using the Respironics BiPAPs AVAP, and on the ResMed Air Curve that are being used in Kashmir. In terms of when you're looking through your machine modes of ventilation, it will be ST mode, okay? And that stands for spontaneous time, then we'll talk about why in a second. So on your machines, CPAP will, on the mode setting, say CPAP, BiPAP will say ST mode, okay? So how does it work? So the inspiratory phase pressure is triggered by the machine detecting your patient's inspiratory effort, okay? And most of these devices, it's detected by approximately 6 mils of inspired air, okay? The machine will then start to deliver its inspiratory phase pressure, so IPAP, okay, providing assistance for your patient during their inspiratory phase, okay? The machines then alternate between IPAP and EPAP, synchronizing with the patient's own inspiratory and expiratory phases. Back to why it's referred to as ST mode, okay? So ST mode stands for synchronized timed mode, okay? So it will synchronize with your patient's own respiratory cycle. Your patient breathes in, the machine triggers IPAP, your patient expires, it switches to EPAP, and so the cycle goes on, dependent on what your patient is naturally doing themselves, okay? So the machines that I've talked about that you guys are using, the ResMed and the Respironics. On the Respironics, they'll within BiPAP, there's a setting called trigger type. Okay, so when we're in BiPAP mode, we would check all our settings, our IPAP, our EPAP, our FiO2. We'll talk about some of those in a minute. There's a setting called trigger type. Okay, you need to make sure you've got the correct trigger type selected. Okay, so with Respironics devices, we should select auto track. Okay, auto track is how the machine works most effectively, synchronizing with our patients. Okay, if you have patients with very low respiratory effort, you can use auto track sensitive. Okay, so auto track will be triggered by 6 mils of inspired air. Okay, auto track sensitive will be triggered by 3 mils of inspired air. Okay, good for pediatrics, good for patients with a very weak respiratory drive. With your ResMed machines, your trigger type settings are different. They're just called very low, low, medium, high, or very high. Okay, again, I've actually managed to find some user guides and things for the ResMed air curve device and the BiPAP AVAX Respironic device. So if needed, I can get them sent to Saeed and he can circulate them amongst you guys. So how does IPAP help? IPAP reduces respiratory muscle effort because it provides assistance during the inspiratory phase, okay? It will increase tidal volume, okay? So it increases size of breaths, and as a result, will reduce respiratory effort and increase carbon dioxide removal. It reduces respiratory rate because breaths become more efficient. It reduces difficulty in breathing, worker breathing, and accessory muscle usage, okay? All of those things increase oxygen consumption and oxygen demand. So as a result of reducing these things, it will reduce patients' oxygen requirements and oxygen consumption. It improves alveolar ventilation. We've said that because it has a PEEP effect, it has EPAP, but primarily the IPAP will influence carbon dioxide removal, as well as providing support during the inspiratory phase. EPAP, we've said, so we have IPAP, EPAP. EPAP, expiratory positive airway pressure. It's the same as CPAP, same as PEEP, okay? And we've talked about CPAP and PEEP earlier. So it applies positive pressure at the end of the expiratory phase and influences oxygenation. So for BiPAP, okay, what settings do we use outside of COVID? So patients with type 2 respiratory failure or acute hypercapnic respiratory failure, on our machines, it's ST mode, okay? We would start with pressures of nationally, our guidelines in the UK from the BTS, we would start with pressures of an IPAP of 15 centimetres of water and an EPAP of 4 centimetres of water. Our national guidelines are to then, with the patient, increase the IPAP by increments of 1 to 2 centimetres of water every 5 to 10 minutes, as long as the patient's tolerated, up to a peak IPAP pressure of 20 centimetres of water. Okay. So our target pressures to start therapy with BiPAP would be an IPAP of 20 and an EPAP of 4. Okay. Now, some of the other settings that we've got within BiPAP on our devices, okay, for both your ResMed and Respironics machines, rise time, okay? Rise time is a time we want the machine to use to reach the peak IPAP, okay? So the length of time our machine is going to go from an IPAP of 4, because it will always start at the EPAP level. So the time it takes for the IPAP to go from a 4 centimetres of water to 20 centimetres of water, okay? Why is that important? It's important because if you've got patients that are very tachypnic and you have your rise time set long, the machine synchronizes with the patient. So when they start to expire, the machine will switch back to EPAP, okay? Even if it hasn't delivered the IPAP pressure that you've asked, okay? So we recommend you have your rise time set low for patients with a high respiratory rate. So 25 plus, we would set our rise time low. We can prolong or increase our rise time when the patient's respiratory rates start to return to a normal level, okay? Why is that important? It's important again because it's about patient comfort, and I'll try and demonstrate that on our machines that we use here with a fake lung, okay? And hopefully you'll be able to see it, okay? But in theory, it's the inspiratory phase being delivered in 0.1 seconds in comparison to 0.6 seconds. Obviously, the longer time, the more comfortable that's going to be for your patient, okay? What we want though in our patients that are very tachypnic is for them still to get the therapy we've asked, okay? So we might need to deliver that rise time quite quickly. Breath rate in the settings is for our backup breath rate. So we said it's ST mode, synchronized timed mode. Timed is a safety function. If our patients become apneic or their respiratory rate suddenly drops, the machine will deliver timed backup breaths for our patient to keep them safe, okay? So breath rate in the settings is whatever respiratory rate you want the machine to make sure your patient maintains if they suddenly become apneic or drop their respiratory rate. National guidelines here are to have that backup rate set at 16 to 20 breaths a minute. The key is this backup breath rate should always be set lower than your patient's actual own respiratory rate. If you have it set higher, the machine is going to start triggering timed backup breaths, and then it will desynchronize with your patient and they'll just become intolerant of the therapy. Our I time or inspire time, okay? This is the inspire time for the backup breaths if the machine needs to deliver any. National guidelines is for patients with chronic lung diseases to set the I time for the backup breaths at 0.8 to 1.2 seconds. For patients with muscle wasting diseases or physical deformities, it's to have your inspire time set a bit longer, so 1.2 to 1.5 seconds, okay? The reason the difference is patients with chronic restrictive lung disease have tighter, more rigid airways, so can't tolerate as well longer inspired times. FiO2, what do we set? We set to maintain our patient's target saturations. Commonly in these patients that have got an acute hypercapnic respiratory failure, our target saturation would be 88 to 92%. Okay, so however much oxygen your patient needs to maintain their target saturations of 88 to 92% or whatever they are, okay? What about giving too much oxygen to patients with acute hypercapnic respiratory failure? If they're on BiPAP, it's safe. We can give them as much as they need because we're in control of what's happening with their therapy. Ramp is an option. Again, it can be off, but you can use ramp as an option if you've got a patient that's struggling if you're struggling to get them onto their therapy. So ramp, you can ask the machine to gradually increase the IPAP pressure over a set period of time. So for example, if you wanted to start your IPAP at 15, but your patient was struggling, the IPAP in ramp always has to be started as whatever your EPAP is. So you would ask the machine to start the IPAP at 4, increase it to 15, and give it a set period of time to deliver that over. So you might say 4 to 15 in 30 minutes, and the machine will automatically ramp up the IPAP pressure until it reaches your target level. And then both devices, so ResMed and Respironics, okay, we have an option within BiPAP called AVATs in Respironics machines, or in your ResMed machines, it's IVATs, okay? But this is basically an alternative way of delivering your therapy. So in AVAPs or IVAPs, this is a volume assured pressure support. Okay, so it's volume control within a set range of inspiratory pressure. So stay with me, guys. We can do questions afterwards. For example, if we're using AVAPs on BiPAP, what we then do is we ask the machine to guarantee us a tidal volume for our patients, which we would base on our patient's ideal tidal volume dependent on height, age, sex, etc. Okay, so for example, if we wanted our patient to have a desired tidal volume of 500 mils, we would, in AVAPs, tidal volume would be set at 500 mils. We would then set an IPAP range, so a pressure range, and we would say a minimum IPAP of 5, 6, 7, 8, whatever you choose for it to be, a maximum IPAP pressure of 20, 25, 30, whatever you want it to be. The machine will then automatically use whatever IPAP pressure it needs to deliver to guarantee your patient has an expired tidal volume of 500 mils. Okay, so traditionally we would just tell the machine what IPAP we want it to use. With AVAPs or IVAPs, we tell the machine what we want our patient's tidal volume to be, and the machine decides on the pressure it needs to use depending on the range that we give to it. Okay, other key within CPAP, okay, and within BiPAP, as well as actual therapy settings that we've talked about in terms of IPAPs, EPAPs, FiO2s, and comfort settings in terms of flex, rise times, ramps, etc. Okay, we also have safety alarm settings. So please always check and set appropriate safety alarms for your patients.
So can we just interrupt you here? So there's a very good question from audiences. What about the rise time and ramp time in AVAPs? Can you set those at all, or about rise times? How does it?
Yeah, you can still set your rise time in AVAPs. It works exactly the same way.
Yeah, you know, I'm a big fan of AVAPs, but the only thing I find is much once the patient's acute phase settles down, doesn't work as well when the patient is very hypoxic.
Yeah,
we'll put them on AVAPs once they've been
I
settled.
was going to come to that. So sorry, is exactly right. So for experience, actually, it's interesting because there's not a lot of evidence out there about the use of AVAPs or IVAPs in terms of non-invasive ventilation. Obviously, volume control modes of ventilation for patients intubated are quite commonplace, but actually for non-invasive ventilation, there's not a lot of evidence and research out there. In terms of clinical experience, as Saeed said, we have tried specifically, we've done a bit of work together in A&E here. When patients present acutely breathless, okay, and acutely hypoxic, AVAPs tends to not be particularly useful, okay? We get a lot of desynchrony, a lot of intolerance in the patient, a lot of patients that tend not to be making particularly good progress, not getting worse, but not getting better very quickly, okay? So what we tend to do with patients when they present acutely unwell is use our BiPAP machines in a traditional way where we set the pressures, okay? And we would repeat blood gases, etc. And once they become a bit better and a bit more stable, we would then convert them to AVAPs, okay? AVAPs or IVAPs is good for the patient. So traditionally we say we want the machine to deliver 20 centimeters of water of pressure of IPAP. Every single inspiratory phase, your patient is going to receive an IPAP of 20, okay? And those of you that haven't tried CPAP or BiPAP, 20 centimeters of inspiratory phase pressure is hard work, okay? It's hard work. With AVAPs or IVAPs, what you get is you're asking the machine to deliver a volume using a range of pressure, okay? So when your patient is not in their extremist acute phase, but a bit more settled, we start them on AVAPs with a volume, for example, tidal volume of 500 mils and a range of IPAP of 5 to 30. It may be that the machine is needing to use an IPAP of 25, 30 to achieve that tidal volume because they're still quite acute and still quite restricted in their airways. As they improve and their airways become a little bit more pliable, okay, it may well be that the machine needs to use less pressure to deliver that volume, okay? So you will look at a gradual, what you should see in your patients as they're getting better within AVAPs is your volume will stay the same because you've set the volume, but the pressure that machines needing to use to deliver that volume should start to slowly reduce. Okay, important. It's important because it becomes more comfortable and more tolerable for the patient because they're only receiving as much pressure as they need to at that given time. So BiPAP so this was traditionally BiPAP patients with acute hypercapnic respiratory failure for whatever reason. BiPAP with patients who have COVID-19. Okay, the jury's out. Again, there's not a lot of evidence out there. People are still collecting all their data. It's very much trial and error. Okay, so again, I'm speaking from experience and experiences that we've had here in our trust. Okay, we have some of our intensivists here that like to try it. We have some of our intensives here that think it provides absolutely no benefit at all. Okay, so with COVID-19 and an acute hypoxic respiratory failure, our first choice of non-invasive ventilation would be CPAP. Okay, if we've got a patient on CPAP with COVID, on PEEPs of 10 to 12 centimeters of water and FiO2s of greater than 60%, with respiratory rates that remain persistently above 30, okay, these patients are going to start to get tired and exhausted. Okay, we would consider switching them to BiPAP. Okay, at which point, if we did that, we would use EPAPs of anywhere between 6 to 12 centimeters of water and IPAPs of anything between 6 to 16, or sorry, pressure support of anything between 6 to 16 centimeters of water. Okay. What we would normally do if we switched COVID patients from CPAP to BiPAP is reduce their PEEP. Okay, so if they're on CPAP on a PEEP of 10, if we switch them to BiPAP, we would put them on an EPAP of 8. Okay, because additionally they're getting inspiratory pressure as well as the EPAP. Okay. When we're talking about pressure support, okay, so hopefully you all understand, those of you that have done intensive care medicine and respiratory medicine might know the difference. So intensive care will talk about PEEP and pressure support with bi-level ventilation. They talk about PEEP and pressure support, okay. Translating that to our BiPAP machines, our PEEP is our EPAP, our pressure support is our IPAP, okay. So if you're in intensive care and you've got a patient on a PEEP of 10 and a pressure support of 6, if you've got a patient on a BiPAP machine, that's an EPAP of 10 and an IPAP of 16. Okay, it's a difference. Your pressure support is a difference between the EPAP and the IPAP. Okay, so COVID patients on BiPAP, an EPAP of 6 to 12 with a pressure support of 6 to 16. So if you've got a COVID patient on BiPAP with an EPAP of 10, our IPAP can be anything from 16 to 26. Okay, all right, mixed results, very mixed results. Some patients find it on a very basic level just more comfortable. Some patients find it much more uncomfortable. It might help resting patients once they're starting to get tired, okay, and start to become exhausted. Also, at that point, we need to think about what's their treatment in terms of escalation, okay. You know, so patients that are getting exhausted, if they're for intubation, probably they're at that point. Your patients that are ward-based care or not suitable for intubation, and they start to get tired on CPAP, it's worth considering trying them on BiPAP. Okay. Again, there's not a lot of evidence. It's mixed results, and yeah, it's very much patient dependent. So hopefully the feedback right now from this slide is going to be that you guys are going to all message in to say, these are 2 of the common machines that you use. Because if it's not, I've got my research all wrong last night. So on the left,
the right one
on the left, we have a Philips Respironics BiPAP AVAPS machine. That's ventilatory modes are CPAP, S mode, so that's just synchronized mode, so just working with what the patient's doing. ST mode, which is traditional BiPAP, which is synchronized backup time breath mode. T mode, which is just time, so that's just the machine delivering all the breaths you know, which is not ideal because we want the patient to be naturally in control of the machine rather than vice versa. And also PC mode, so pressure control mode, okay? Within, sorry, you can't see what I'm pointing at. So with your Respironics BiPAP AVAPs machine, ST mode is where you will find your AVAPs function as well, okay? So you can use ST mode traditionally, set the IPAP and set the EPAP, or it has an AVAPs function where you can set a volume control and then give an IPAP range. On the right, we have the ResMed AirCurve ST machine, which I think is on some of the pictures I've been sent. Okay, and modes of ventilation on this machine are CPAP, again, synchronized mode, ST mode, which is BiPAP. Okay, PAP mode. Also on the ResMed AirCurve, IVAPS is a separate mode. Okay, so on your Respironics machine on the left, to activate AVAPS, if you want to use it, you go into ST mode. On your ResMed AirCurve machines, you've got your traditional mode of BiPAP, which is ST. It also has a mode outside of ST, so it has CPAP, SCPAC, IVAPS, okay? On your ResMed AirCurve machines, IVAPS is exactly the same as AVAPS, okay? They just call it a different name. It's a different manufacturer. So masks, one thing that I haven't been sent through is what sort of patient interfaces you guys are using.
That's a lot of questions about the masks.
So this is, would be good to know. Okay, so what I'll show you here is, point it at the camera.
Yeah.
So this is during COVID, so during the pandemic, this is our go-to choice of patient interface device that we use for our patients on NIV. So this is what we call a full face mask, okay? It sits on the slide there that you've got. On the left of the screen is how it fits to our patient, okay? We get very good fits with these masks, okay? And believe it or not, in spite of how claustrophobically looking it appears, patients tend to tolerate these face masks very well, okay? So that's our go-to mask because it fits better, we get less leak. We also have our other standard face mask, okay, which is the one on the right of your screen there. So that's this one here. Now this fits. So the patient's nose, the bottom of their nose and nostrils sit here. Okay, you've got a little hole there for the nostrils there. Okay, and this section here underneath sits in between the bottom lip and the bottom of the chin. Okay. So as an adjustable flange for the forehead for patients that have got different shaped faces. Again, our go-to mask is a full face mask during COVID, okay? Guys, just remember whatever device you're using, okay, and I have looked, so with the ResMed and the Respironics machines that you've got there, they both have a compensatory facility, okay? So the key as well with masks is whatever mask you're using, patients shouldn't be getting pressure sores on their face, okay? These masks are designed to sit comfortably on your patient's face, okay, without being strapped so tight that they're starting to get sores on their faces, okay? Both types of machines, ResMed and Respironics, have a leak compensatory mechanism built into them, okay? So they will compensate for small amounts of leak, okay, which allows you to not have the mask on completely tight. You should be able to, hopefully you guys are familiar with the settings and how they work.
I just would like you to show the circuit and everything. What is filter going through.
Yeah. So in terms of leak, I'm not sure about the ResMed because I did look, it did say that it has leak compensation, but it didn't say to what amount. The Respironics devices have a leak compensation up to 60 litres per minute. Okay, so if there's an air leak of up to 60 litres a minute, for those of you using the Respironics machines, the machine will compensate for that and just deliver extra pressure to compensate for that leak. Okay, so while we're talking about the mask, we'll talk about, sorry, I just said about the circuits. I can bring this out.
This one, you can see it.
Yeah, but can I see it there?
Yeah, I can see it.
Oh, okay. Okay, so with our devices here, okay, we have The circuits that we use, again, these are, so guys, I know things are very difficult in Kashmir. We have single patient disposables, okay? Ours come pre-set up. So if I'll start from scratch for you guys. So we have how we use it, and this again is our national guidelines for NIV, okay, during the pandemic, is we have one antibacterial filter that sits at the inlet or the outlet port for the device, okay? This filter protects your machine from contamination, okay? We then connect our disposable circuit tubing, okay? We then connect whatever patient interface device it is we're going to use, okay? So that for us is our full face mask, okay? And then on our expiratory port here, okay, we put another antibacterial filter which protects our environment from contamination, okay? Now, both filters should be changed every 24 hours, okay? The national guidelines in the UK are, it is acceptable. So first wave of the pandemic, every single disposable for NIV was very short supply because of the demand, okay? So our national guidelines are, if you're short of filters, it's acceptable to use one filter, okay? So we would connect our tube into the outlet port of our machine, and our one filter that we've got, we would then place in between the patient's device, and so it sits protecting your machine from contamination, okay? And your environment from contamination, okay? All right, and it also protects the patient from anything else going into them as well. All right, so what does that make sense?
Yeah.
Can you see that?
Is it different to your HEV filter, or is it, how does it protect it?
So just an antibacterial filter, yeah. So whatever your standard antibacterial filters are, doesn't need to be HME. Okay. We sometimes do. So I know that actually, I feel like from colleagues that I work with that are from India, you guys are having a very hard time in terms of equipment. I have to say I was a little bit shocked when I saw some of the machines we're using, because the ones that the pictures that you've given me, they're the devices that we use for our patients for their domiciliary NIV, so they use them at home. So we use a little bit more high-tech stuff in our hospitals. However, what I will say is our NIV machines that we use here, if it makes you feel better, are non-humidified, okay? Whereas it looks like the ResMed and the Respiratory ones that you guys are using are humidified. So your patients have got that on their side in terms of we have to use nebulization and stuff to give our patients humidification. Okay, so that's circuit setup. We can come back to questions around that. Obviously, okay, non-invasive ventilation, CPAP, BiPAP, it is not a treatment, okay? It is not a treatment. There is an underlying cause for whatever sort of respiratory failure your patients are in. So we need to not forget to treat our patients medically for whatever the underlying cause is. So oxygen, GTN, furosemide, opiates, nebulizers, antibiotics, steroids, physio, okay? Always in the UK, any patients acutely that we're starting on NIV, we would make sure that they've got a clear plan in terms of what are their ceilings of care, what's their status of escalation, what's their status for resuscitation, all of those things to be clearly discussed and documented in their notes. Okay, so care of our patients receiving non-invasive ventilation, okay, it can be undertaken by whoever, nursing staff, medical staff, whoever. So vital signs monitoring in terms of observations, heart rate, blood pressure, respiratory rate, blah, blah, blah. Minimum of hourly observations, vital signs monitoring when we start their treatment. Okay, continuous saturation monitoring and continuous monitoring of respiratory rates. Regular patient comfort checks. Okay, also checking the synchrony with the machine, the settings that we've got the machine set at. Do we need to adjust any of them? 12 lead ECG before we start NIV, and also cardiac monitoring for the first 12 hours. Ensure that patients have got adequate blood pressure. Okay, we spoke about the fact that positive pressure ventilation can reduce cardiac output and reduce blood pressure. Fluid status review. Okay, patients are going to find it difficult initially when they're acutely unwell on NIV to take in adequate amounts of oral fluid. So it may well be that they need supplementary IV fluid therapy. Also think about things like gastric distension. It may well be if your patient's on an IV and they start to feel nauseated, might be worth considering putting down an NG nasogastric tube to help prevent gastric distension and vomiting. All right, in terms of blood gas monitoring, we would, once we've reached our peak therapeutic pressures, repeat an arterial blood gas after 30 to 60 minutes, okay? And then 1 hour after any changes we make to the settings. All right. We have our respiratory ward here in our trust. When our patients are on the respiratory wards, the nurses on those wards are skilled to take and interpret capillary blood gases, which are much kinder for the patients. Okay, review oxygen status. Okay, do we need to adjust or titrate oxygen delivered up or down? Ensure nutrition is maintained. Okay, so even if they're not able to eat, we can think about high energy nutritional supplements, regular mouth care, regular pressure area care checks in terms of their face and around the mask. Like I said, they shouldn't be on tight enough to cause pressure areas. And constantly reassessing the patient and the machine to make sure they're both working nicely together. So when would we wean? Okay, in terms of BiPAP, we would consider weaning when the pH is returned to normal. Okay, when patients' parameters of observations are within normalish ranges for them, when their concentration of oxygen is down to a reasonable amount. Okay, and in terms of BiPAP, we talk about keeping it on as much as possible for the first 24 hours. Okay, very small breaks for drinks and food if patient can tolerate it. And then when we wean off BiPAP, we wean in terms of time of period off of the therapy. Okay, so we don't wean pressures, we wean length of time off the therapy. So it will be 24 hours on day 1, for example, 16 hours on day 2, 12 hours on day 3, and then thinking about discontinuing day 4 if the patient's able. Any breaks from NIV should never be taken overnight. Okay, so overnight, if your patients need an NIV, they should always be wearing an NIV at night time. Okay, and then I've just said, we don't suddenly stop therapy. If we suddenly just stop and take patients off non-invasive ventilation, 9 times out of 10, they will need to go back on it. Okay, we need to make sure we're weaning them off it slowly and properly. Okay. Any repeat blood gases in terms of monitoring that we're doing should always be taken and sampled when the patient is receiving their oxygen and or their NIV. Okay, we should never be removing oxygen or NIV or high flow nasal cannula to do blood gases. Okay, the only time here that we would do that is if we're assessing any of our patients for domiciliary oxygen therapy. So humidification, you guys hopefully looks like from the pictures have got humidified NIV machines, so your patients are getting humidified ventilation. We use nebulizers for our patients if they can tolerate being off the device for long enough to have it. So we would give nebulizers traditionally for a normal face mask, normal aero chamber, okay, and connect up to a compressor or the flow meter on the wall. If our patients can't tolerate it, we've got a little T-piece connector where we can give the nebulizers through the BiPAP or CPAP circuit. A&E are very posh. They've got little sonic nebulizer devices, but they only fit to our face masks that we currently don't use for COVID. So they don't fit to the full face mask, I don't think, as far as I'm aware. So complications of non-invasive ventilation, discomfort, that horrible feeling of breathing against pressure, mask fit too tight, incorrect mask. Okay, think about what your patients prefer. All right, so I said that we try and use a full face mask. If we've got patients that find them too claustrophobic, we will use the other mask device if we need to. Okay, so it's about what's going to be best for the patient, but also what is going to help the patient tolerate and comply with their treatment as well. Poor oral hygiene, hypotension, noise, pressure sores, gastric distension. Contraindications, okay, lots for NIV, not like high flow nasal oxygen. So facial trauma, burns, vomiting, upper airway obstruction, life-threatening hypoxia, any facial upper airway or upper GI surgery, reduced DCS, undrained pneumothorax. The list goes on, okay, they're all on that slide. However, our national guidelines are, the ones that we've got asterisks there, our national guidelines are, if the patient's ceiling of care is non-invasive ventilation, i.e. they're not a candidate for intubation and ventilation, we still can use NIV in the presence of the asterisk contraindications, okay? It is about reducing the risk and making it as safe as we can within the confines of what we're trying to do. So when would we stop? Okay, we're not talking about weaning, we're talking about stopping therapy. We would stop because the reason for commencing is resolved, okay? So if you're thinking about CPAP, sometimes we'll just stop CPAP. If there's any non-compliance, okay, if a patient's non-compliant with therapy, there's no point trying to persevere with it, because what that will do is it may create stress which outweigh the benefit, okay? If your patient's more stressed and more anxious because they're non-compliant and you're trying to get them to persevere with it, sometimes you just have to take it on the chin and say, actually, let's just stop, we'll try something different. If the treatment is failing, okay, so treatment failure, do we need to escalate higher, so escalate to intubation, or do we need to, if treatment's failing, consider palliation? So we talked about ceilings of care, what's appropriate for our patients, okay, so we need to think about also ceilings of care in terms of ceilings of pressures. How much pressure is it we're going to give before we start to say, actually, we need to think about something else, or we need to think about patient comfort, patient dignity, patient respect. Okay. And like I said at the very start, always talk to your patient, always talk to your family, let them know what's happening, what's going to happen, how things are going to feel, what the options might be if things are not working. Because what we find is, when then that happens, they tend to be much more accepting of what's going on. Any questions? So I felt like I talked loads then.
No, still, I think you must be exhausted. I know you've been off on night shift, so if you want to sit down,
Yeah, no, it's fine.
you're very tall.
Right.
So there's it's gone ballistic, the chat box. So it'll be a rapid fire, so quick answers, so hopefully. And one of them is, what should be the minimum gap between the IPAP and EPAP? I know you spoke.
Yeah, great, because I normally mention that. So the key is, we said about the gap between the EPAP and IPAP, if your intensive care ward is pressure support. Okay, so if you're using BiPAP because of an acute hypercapnic respiratory failure, to achieve any level of carbon dioxide clearance, your pressure, the pressure support needs to be a minimum of 6. Okay, a minimum of 6 to achieve any carbon dioxide clearance, if you're using it for an acute hypercapnic respiratory failure. So what we advise is, if you're adjusting pressures with your IPAP, you can go up and up and up and up as a standalone pressure, as long as your start off point was a pressure support of 6. If at any point you need to increase EPAP for whatever reason, so hypoxia or whatever reason, if you increase the EPAP, you should increase the IPAP by the same amount, okay, to maintain the level of pressure support. Does that answer the question?
Absolutely. I think that's very black and white, really. You have to have the pressure support for good ventilation. Next one is, I hear this a lot. There's less tolerance of NIV in our setting. I think they should come here. Patients with pretty high respiratory drives, both pathological and anxiety-driven, are less likely to tolerate NIV. Plus, the generalized perceived poor outcomes with invasive ventilation has made decision-making complicated. So a lot I hear is, when people are put on the mask, they become very tachycardic, they start fighting, which we see here also. So what are the tricks you would say, or the keys to beat that? So
especially with patients with COVID, this has been an awful problem with anxiety and I wouldn't even really say non-compliance, I would say intolerance, really. So with COVID, it's been a big issue. So first key message is, and I keep saying it, is please try and explain the therapy properly to your patients as clearly as you can. what the patient can expect, how it's likely to feel for them, what the risks and the benefits are. You know, obviously we all understand that the benefits far outweigh the risks. Okay, so that hopefully would help. Failing that, we do, especially with our COVID patients, we were using low levels or low doses of relaxant drugs, so diazepams, opiates, so occasionally maybe oromorph or morphine, low doses diazepam, whatever your kind of classification within that classification of drugs you're comfortable to use. Okay, the key is that these patients have already got respiratory compromise. Okay, so we don't want to be giving them big doses, but if they need it and they're agitated, there is low risk of giving them a low dose. So we would quite often give our patients 2 milligrams of diazepam, just enough to settle them to be able to tolerate their therapy.
Exactly. So,
and the other thing is obviously ensuring that you've got your machine set up as best as you can to work with the patient, i.e. not pressure's no higher than they need to be receiving. Comfort settings, if you want to use flex in CPAP, if you're looking at your rise times and ramps and all of those sorts of things in BiPAP.
I think which has been asked is because patients tend to be on BiPAP for a long time or NIV with COVID. It's not like for pulmonary edema, a few hours and off you go. Yeah. So how do you address nutrition? And is it an option to put an NG tube, or how often should breaks be?
So for nutrition, again, it's about your patients. If your patient can tolerate being off NIV long enough to be able to have something to eat and drink, absolutely, that's the best way for them to do it. Okay, without question. It makes them feel more human. Okay, it's a more natural thing to do. So, however, a lot of these patients can't tolerate, in terms of hypoxia or worker breathing, to be off. So your options are utilising high flow nasal oxygen if you've got it available for that transition. So we would quite often take patients off CPAP, put them on high flow nasal oxygen, let them have something to eat and drink, and put them back onto CPAP if they can tolerate it, if it's available. If it's not available, you might need to consider things like we said, supplemental IV fluids, fine bore nasogastric enteral feeding. Okay, and when we say fine bore, so our tubes that we use for enteral feeding nasogastric tubes are 10 French, so very fine bore. Okay, because whatever size tube you use, it is gonna impact the fit of your mask device that you're using. Okay, so the key is, but your patients will need to have nutrition. So if they can't tolerate eating and drinking normally, you will need to consider nutritional supplements. So we use sort of 100 ml shots of high energy nutrition supplements, or fine bore nasogastric feeding.
Can I come into that?
Yeah, yes.
We did discuss that on the chat. The feeding, as Steve mentioned, that's exactly what we mentioned. We did mention that we can give prokinetics like metoclopramide or erythromycin, and we can also, some of these things are not available always in Kashmir, but there are some gastric decompression devices that can be used. We discussed the sealing aspect as well. So if you go into the chat box, there's all there. With regards to sedation, that's a very tricky subject, and some of our colleagues mentioned that they use sedation in ICU, which is perfect. In ICU settings, sedation can be used by experts, but you have to be very careful not to recommend sedation in NIV at other places other than ICUs.
Oh, sorry. Just for clarity, I'm not recommending sedation. I'm I'm suggesting very, very low doses of anti-anxiety medication.
Absolutely. Yeah. I'm just taking Kashmir into account, and our friends, some of them are using probably dexmedetomidine, which is which is an excellent drug, and that's got very low respiratory depressant effect. We can use for TCIs, but they are quite advanced. You need pumps and etc. for that. But that's fine. That's been addressed. Thank you very much.
I think we found with one of our colleagues, actually, he was so anxious and he was getting so worked up. We just gave him anxiolytic, not sedation, and he was fine on just ordinary oxygen after that. So there's a role for it, but in the right medical setting, and use it judiciously. Otherwise, you can cause more harm, as we all know. I think there's a few other questions which you can take up in the panel discussion after this. So unless there are any burning questions for Steve, I would really like to give a round of applause if I can virtually, because he's come from night shift. He went home, slept for 2 hours, and came back. I owe you big time, Steve, and thank you very much. Very, very grateful.
Dr. Imtiaz, can I just thank Steve on behalf of all of us in Kashmir?
Oh, thank you very much.
Thank you, thank you. Thank you, Steve. It has been a lovely talk from you and very enlightening one. And definitely it will help all of us in this part of the world. Two things what I wanted to add in what we use in Kashmir is the high flow nasal oxygen by Fisher and Paykel.
Yeah.
And we have, as there were some comments as I was seeing in the chat box. We have a disinfection tube attached to that, and there's a red color disinfection tube. And once we attach it, what the company manual writes is that the temperature it rises to around 86 degree.
Zulfi, is the same one? Zulfi, is it the same one or a different one? This is what we use.
I'm not seeing. Do you have one there in the? I can't see anything there.
I'm just showing it at the camera.
Yeah. It's what we have here is what's the model, exact model that you guys use there?
So our model is an Airvo 2.
Yeah, exactly. Yeah, it's the same one. It's the same one. Yeah.
So the same kit.
So we use it for reprocessing. Once we use it from one patient to the other patient, this disinfection tube is used for disinfecting the equipment.
Yeah, so the key is when we're talking about the high flow, so that with the Airvo 2, the patient disposables, i.e. the nasal cannula, the water chamber, and the trunk tubing that go from the water chamber to the nasal cannula, with that single patient use here. So once the patient's finished with it, it goes in the bin. Okay, it's discarded. In terms of this, in terms of the decontamination tube that we're talking about, the red one, that's multiple use. So that's non-disposable.
Yeah, that's non-disposable.
So we keep these with each machine, and each time it's finished with a patient, we use the same tube to decontaminate the machine.
Yeah, what was in my mind, for example, if we use disposable kits, what about the filters and the other parts in the HFNO? Do they get contaminated? So do they need to be changed in an ideal situation? As
so they are, ideally, the filters at the back, so they've got the little filters in the back of the machine, they should be changed in between each patient as well.
Okay. So if we do not in an ideal situation change this, so once we use this disinfection tube, will it really help to reduce the cross infection to some extent, if not totally?
It will. So actually, interestingly, the manufacturer's guidelines, so Fisher Paykel's guidelines in terms of the cassette filter, so that if you guys can see this on here, can you get down to that? So so at the back of the machine,
yeah.
So we've got a little strip cassette filter, okay. All right. So if you guys can see that there,
Yeah, they can.
All right. So I think this is the one that Yas is talking about.
Yeah, exactly.
So we recommend that these are changed in between patients, okay. However, the manufacturer's guidelines is that these are changed, I think it's approximately every 1,000 hours of machine use, okay? And I don't know if you've seen it on your Airvo 2s, but actually it does come up with a message on the little screen. If the filter needs changing, it will prompt you to change the filter. So if you are keeping the same filter in between multiple patients, you will eventually get a message that pops up on the screen advising you to change the filter because it's reached its time period of use.
Fine, thank you. And Steve, I had one more query. Initially, once we started using HFNOs, there were some papers that came from United States. Again, some of our colleagues had mentioned it, that once we use HFNC, if we apply a face mask over the HFNC, it reduces the chances of aerosol dispersion. There has been some mention of it in the review, and I saw some guidelines, particularly from the University of Pennsylvania and Seattle. So what they do in their institutional protocols, they apply a face mask. So
Yes.
what is your practice in UK? What do you do in UK?
So I might have got a previous question mixed up because I think this might have been asked for. So when I was asked before about face masks over the top of high flow nasal oxygen, I thought somebody was talking about an oxygen face mask over the top. Okay, so but I'm assuming you're talking about infection control face masks, so it's like surgical face mask. Is that right?
Yeah, exactly.
Yeah. So I mean, it makes sense if you've got a patient on high flow nasal oxygen for them, if they've got a surgical face mask over the top, it would reduce the risk of aerosol contamination. Okay. However, as I've previously said here, our patients that are on aerosol generating procedures are either isolated in their own room with negative pressure and ventilation, or cohorted in a bay with other COVID patients on aerosol generating procedures. Okay, so the cross contamination risk is low. Okay, because we're talking about cohorted patients all on the same treatment, all with the same infection. Okay, the other thing to consider is we've talked about the fact that high flow nasal oxygen is heated. Okay, and so patients quite often will struggle with the heat and the humidity anyway. And once you put a surgical face mask over the top of that, it makes it worse. So it's difficult in terms of, I don't know the intricacies in the logistics of where you're managing these patients. But definitely if there's a risk of exposure to non-infected patients or non-protected healthcare professionals, then it would make sense to ask them to wear a surgical face mask. However, it will probably cause difficulties in terms of you're putting a face mask over something that's already hot and humidified. That's likely to compound that problem.
Can I come in at this point? In terms of aerosol generation and high flow nasal cannula oxygenation, if you go onto Fisher-Paykel website, there is a paper they have put on the website, and it has been I think taken off aerosol generating procedures now, because the recent studies have suggested that or demonstrated that it's not aerosol generating anymore. So that you can check out. Yeah. So I think the risk is probably lower than we thought earlier, like last year.
Yeah, I think we've certainly found here during the first wave of COVID, we weren't really using high flow nasal oxygen because of its oxygen consumption issues, but also B, because we had concerns about the level of aerosol generation. But during the transition between waves 1 and wave 2, we actually found out that it actually, in terms of aerosol generation, is definitely no higher risk than non-invasive ventilation.
Yeah.
So Steve, just one question I need to ask. So if a patient is actually coughing, so what would you prefer?
If a patient is coughing,
yeah,
what on high flow nasal oxygen,
or non-invasive ventilation, yeah, using a mask.
So if a patient is coughing, as in lots of secretions on non-invasive ventilation, if they've got copious amounts of secretions and they're coughing, they're expectorating an awful lot, then non-invasive ventilation is going to be difficult. It is one of the contraindications that was on that list, I think, high secretion burden, because the risk is with those patients, we're talking about a high secretion burden, not somebody that every now and again is coughing up a bit of sputum, but the risk for those patients on NIV is if they coughing up a lot of secretions, potentially they're going to aspirate, okay, because it's got nowhere to go, or they're going to be repeatedly taking off the mask, and actually then they're just losing the PEEP and losing the therapy constantly. So if it's an issue, it's about rethinking what would be the best alternative to consider.
Right.
Steve, do you have any experience with the use of vasodilators in patients who have remained persistently hypoxic? Have you used some vasodilators in clinical practice there in UK?
Not so here at the William Harvey in Ashford, we don't do that. So I'm a critical care outreach nurse. So, but the team that I work in, we're part of the intensive care team, but we don't work within the confines of intensive care. So we support all the other clinical areas outside of intensive care, with essentially what are level sort of 1.5 to 2 patients potentially. But we wouldn't use that sort of management outside of level 2 care areas, just because of the risks that go with that.
Can I just add in that in severe ARDS, we do use nitric oxide, but that's only in tertiary care centers and in very few selected patients. Otherwise, no.
Cool. Unless there are any more burning questions for Steve, I would really like Steve to go home and get some sleep.
I stay and listen. So
Oh, sure. Okay, fine. And I think
I'm on holiday now.
As your stamina is amazing, so Steve, thank you very much. So, what I'll do now is
Can we take the presentation off?
Yeah,
so
sure.
that we can start the next.
So, yeah, fine. So yes, I'll hand over to you now. I think for
Yeah.
the panel discussion and welcome the next presenters, please. Thank you, Yasser.
Well, again, thank you very much for all of us and all of you who have attended today.
Thank you so much. Thank you.
It's been an amazing seminar so far. I'm especially thankful to our seniors, Professor Roxana, who is here with us, Dr. Zulfikar, who I have intermittently spoken to in the last couple of weeks in planning this webinar, and my friend Umid, who is here. I'm really grateful for them to be part of this discussion today. And I would lay open this discussion to everyone who is here, because I can see all of you are here and lots of you are anesthetists and intensivists. And I gather you're all interested in knowing lots of things about various respiratory therapies. We will talk about escalation, we'll talk about deteriorating patients. I may start off with I think I will start with a brief presentation by Dr. Ruxana Najib, who is Professor of Anesthesia and heads the department at Government Medical College, Srinagar, because then we'll have the rest of the discussion open. We do have another brief presentation from Dr. Zulfikar, who has amazingly done that presentation because he had to go to Delhi for some urgent work. Thank you for that, Dr. Zulfikar. So let's start with Professor Roxana to begin with. Thank you very much.
Good evening all, and thank you for inviting us. And thanks, Mr. Steve, for an academic fest. So I start with oxygenation, ventilation in SARS-CoV patients in GMC Srinagar and associated hospitals. So we all know this was a global pandemic and it didn't spare any of the countries. So at the outset, it was a blow to all of us because we were just doing our routine cases, and then we had to adjust ourselves to this pandemic. So SARS-CoV-2 is primarily a lung disease which causes pneumonia, affects ventilation, oxygenation, thereby affecting other organ systems. So our main goal was to provide oxygen therapy to these patients. Now, how do we do that? We can go for normobaric oxygenation or hyperbaric. Normobaric at ambient pressures, so patient can breathe on their own without assistance. So you can use low flow device and high flow device. Or at normobaric, we can go to positive pressure ventilation. Patients can breathe on their own, but need ventilatory support. So we can use non-invasive ventilation, that's NIV, CPAP, BiPAP, which has been discussed elaborately by Mr. Steve. And patients who cannot breathe on their own and need to be intubated, So we go for invasive endotracheal intubations and tracheostomy. We have really done all these cases here. So most of the times, Dr. Steve was saying that we don't see these things in Kashmir, but I think we are well equipped. We got all the equipments in last 1.5 year. And what has changed the outcome of the patients in last 1 year is the high flow nasal oxygen cannula. So it has a flow meter, nasal interface, humidifier, inspiratory tubing, and this has really changed the outcome. Last year, we were really struggling what to do with the patients. We wanted to have an outcome, but most of the patients we intubated last year, we lost most of them except 3 in CD hospital, which we were able to save, and some 7-8 cases in Ward 10 of SMHS hospital. Now, what does this do? The main advantage of high flow nasal cannula is generation of PEEP. It can go from 35 to 50 liters per minute. Flow generates of around 2.5 to 7.5 centimeter of water. And mechanism is that high flows from the nasal cannula will increase the pressure in the pharynx, increases the expiratory pressure in the alveoli, keeps alveoli patent during expiration. And the slide was one of our wards in Ward 10. Now, what are the contraindications to high flow nasal oxygen? Inability to protect the airway, that is, patient has a low Glasgow coma scale, patient's refusal, maxillofacial trauma, nasal pathology, polyp, atresia, adenoids, foreign body aspiration, severe life-threatening hypoxia. Now, how do we know what is the outcome of the patients on high flow nasal oxygen? And we are following the same index, that is the ROX index. You take the SpO2, divide by FiO2, and the result is divided by respiratory rate. Success is good with 4.88, and we consider intubations if the ROX index is less than 3.8. So we measure them at 2 hours, 6 hours, 12 hours, 18 and 20 hours after initiation of high flow nasal cannula. And we identify the patients who will need intubation if the ROX index is less. Now, overall, we are preferring high flow nasal oxygenation because the patient compliance and comfort is good. Humidification of inhaled oxygen and it washes off the dead space. Patient is able to communicate, consume food and drinks, improved oxygenation, maintains the mucociliary activity in the airways, and prevents sloughing of the epithelium. It preserves the lung volumes. It delivers oxygen at or above patient's peak inspiratory flow rate, hence decreases the work of breathing, avoids intubation and mechanical ventilation, and reduces the work of breathing. We have 5-7 video recordings of patients who were on high flow nasal oxygen cannula, and at some of the point of time, we thought that we may have to intubate these patients, but luckily we got a very good result on high flow nasal oxygenation. Now, disadvantages is that we have to have high oxygen consumption, but luckily all our hospitals are well equipped with oxygen backup. We have back-to-back manifolds, we have back-to-back oxygen concentrators, and we have liquid oxygens now available. And that was one of the disadvantages last year, but now this year, we have made sure that all the ICUs get a good oxygen backup for these patients. So there is frequent refilling of the reservoir water source for humidification. That was explained very nicely by Dr. Steve. Heating of the appliance when run for longer duration. Although it was like initially we had some hitches in using, but now we have got good experience in this, and nasal irritation. We have at least a good backup of these high flow nasal oxygen in all our ICUs. Even in non-COVID ICUs, we have kept these high flow nasal oxygen because we got a lot of stock of these. Now, how to use high flow nasal oxygen, that is what we are doing here. We explain to attendants and patients about the functioning, advantages and disadvantages of its use. We take an informed consent, set up the machine and plug it in the wire to a power source, Choose the nasal cannula of appropriate size. We have all sizes available. Fill the humidifier with sterile distilled water up to the mentioned mark and connect a water source to the humidifier. This is our ICU Ward 10. We have a lot of them. We got so much of equipments this year that we had to take one area in an hospital and stuff the stock there. So keep setting on the display as per the requirement. Set the temperature, flow rate and FiO2. Preheat the system for a few minutes and wait for the sign ready to use on the display. Connect the nasal cannula to the patient and strap it around the patient's head. Now, how do we adjust the flows on the flow meter as per the oxygen flow set on the display to adjust the FiO2? So 50 liter of flow on the flow meter and 50 liter on the display will give you an FiO2 of 1, and 25 liter flow on the flow meter and 50 liter on the display will give an FiO2 of 50. Allow the patient to breathe with the mouth closed in order to maintain the adequate PEEP. Synchronization with the high flow nasal cannula may take about 30 minutes. Start with lower flows and titrate slowly every 30 minutes. This is one of our patients. He is on non-invasive ventilation, and you can see a Meditech ventilator, and every bed is equipped with 2-3 ventilators and high flow oxygenation and multi-channel monitors. This was Ward 10, which was initially a high dependency unit. Then immediately we had to respond to the pandemic and converted Ward 10 of SMHS Hospital into a COVID ICU, although we already had one ICU, Ward 17. So steps for non-invasive usage. Choose the best interference for the patient's tolerance. When available, consider a helmet or full face mask interface to minimize particle dispersion. Use dual limb circuitry with a filter on the expiratory limb of a critical care ventilator. We have full stock of all these equipments. So start with CPAP using the lowest effective pressures between 5 and 8 centimeter water. Early reports suggested most patients with COVID-19 were hypercapnic. So BiPAP was used. BiPAP may result in increased inspiratory pressures without any added benefit. So after that, we would reevaluate patients within few hours of the therapy. And if the patients were not responding, we would consider to other options. Now, advantages of NIV is that we improve the oxygenation, decrease the work of breathing, reduce the sedation, preserve the airway reflexes, and patients can talk, eat, and drink. And we make sure that we give proper nutrition to these patients, and they do interact with their relatives. So we have some point where they do meet their relatives. And non-invasive is easy to apply and easy to remove. Disadvantages were claustrophobia. Really, we saw they were struggling and they would not cooperate. We would see nasal skin and facial skin necrosis. We have video recordings of so many of the patients who had that necrosis. Then pressure on the nasal bridge. There was air leak. It decreases the blood pressure and decreases the venous return to the heart. There is gastric distension. We had to go once to CD hospital for surgical consultation. And then we came to know that the distension was not because of the paralytic ileus or some surgical problem, but it was just the distension of the air into the abdomen. And disadvantages, it increases the NIV, increases dead space, eye irritation, subcutaneous emphysema, pneumothorax. We have rarely seen subcutaneous emphysema where we had to intervene, give multiple pricks, and we have seen pneumothorax in so many of the patients who were doing well with non-invasive ventilation, but then we had to put in chest tube, and then some of the patients deteriorated after pneumothorax. Now, contraindication is if the patient is hemodynamically unstable, if the Glasgow Coma Scale is low, if patient has full stomach, if there is facial trauma, facial burns, uncooperative patients. Now, since we have 1.5 year experience of COVID in our hospital, we were the main hospital which was catering to so many districts. So we constituted an institute-based ventilation protocol for the management. So once last year, only on 18th of March last year, 2020, we had to start ICU in Chest Disease Hospital, because initially Chest Disease Hospital was designated as a COVID hospital. So we went there, started COVID ICU, 11-bedded ICU. Initially it was 4-bedded ICU, and then there was an isolation ward. Then we converted that 4 and 8 beds into a full-fledged ICU in CD Hospital. And initially we were managing all the patients of COVID in Chest Disease Hospital. Then once the rush of the patients was more, then SMHS Hospital was designated as a COVID hospital. And then we started in June, Ward 10 as a COVID ICU in SMHS hospitals. So how do we manage these patients in our hospital is that patients with low SpO2, which are not maintaining saturation, they are admitted to hospital. Mild pneumonia patients were managed in the medicine wards with low flow oxygenation, along with proning and propped up positioning, because we would go to attend the calls. They would call us and tell us to assess the patient for asking us to shift to ICU. So we would see that they really were giving them prone ventilation and propped up positioning. So severe pneumonia and critically ill patients were admitted in our ICU for treatment. Although we had a lot of patients, more than 200 admissions per day last year, per day in SMHS hospital, but we were a referral hospital for GMC, Anantnag, Baramulla, and so many other districts. Now, how did we go ahead with our oxygen therapy in our COVID ICUs? The side screen is one of the COVID wards, but once patients got admitted to our ICU, we would start with first nasal cannula, 1 to 6 liters per minute, face mask, 5 to 10 liters per minute, non-rebreathing mask, 10 to 15 liters per minute. And then when there was no response, we would straightway go to high flow nasal cannula. The range was 20 to 60 liters per minute, or non-invasive ventilation, critically air. And finally, we would resort to invasive ventilation. And in non-invasive ventilation, our target was SpO2 around 88 to 96%. So we are also following the National Institute of Health guidelines for adults with COVID-19 and acute hypoxic respiratory failure. With the conventional oxygen therapy, high flow nasal cannula was our preferred choice over the non-invasive positive pressure ventilation. In the absence of an indication for endotracheal tube, and once we didn't have high flow nasal oxygen cannulas, we would go for non-invasive positive pressure ventilation. Then patients with persistent hypoxia, despite increasing supplemental oxygen requirements, in whom endotracheal intubation was not otherwise indicated, we did a trial of awake prone positioning to improve oxygenation. Last year, we went to, we had 11 patients in ICU of CD Hospital, and we started proning those patients. And after 15 days, the outcome was excellent. So minimum of 16 to 18 hour proning was tried, but it needed a lot of manpower and patients' cooperation. Using awake prone positioning as a rescue therapy for refractory hypoxemia to avoid intubation in patients who otherwise needed intubation and mechanical ventilation. So this was our paper last year. We tried 26 patients on prone ventilation, prone oxygenation. And this paper was presented in one of the conferences of European Society of Intensive Care Medicine. We have done this proning. Otherwise, we were thinking of going for intubation in these patients, and we didn't notice much complications. If intubation becomes necessary, the procedure should be performed by an experienced practitioner in a controlled setting due to the enhanced risk of severe acute respiratory syndrome coronavirus exposure to healthcare practitioners, and also because during intubation, we have seen a lot of cardiac arrests. Because since it was a referral institution, we would get patients at a very late stage. And that is why we lost a lot of patients who were just in severe hypoxia, and we had to intubate, but we lost them within in 2-3 hours.
Polite, we got 3 more minutes to go.
So
Sorry.
which one to choose? Depends on availability of equipments like technical staff, oxygen supply, tolerance, response to treatment. Now, we have already discussed high flow nasal trial for 1 hour. If you are responding, go for invasive ventilation. If not responding, shift to NIV and then non-invasive ventilation. So this is our data of high flow nasal oxygen, 64% of the patients had a good response and 36% didn't respond well to high flow nasal oxygenation. This is again non-invasive ventilation. In 56% patients, we had good response, and 44, we didn't have a good response. So again, this has already been discussed. When to move to next level, that is once oxygen saturation is decreasing, PO2 and serial ABG analysis shows, so we'll go for intubation. Now, if patients are responding to treatment, we go on, we maintain SpO2 between 88 to 92%. This is again about the non-invasive ventilation. And when there is no signs of respiratory distress, ROC index is good. So we have done proning in our patients. We do it in both the hospitals, and we have seen that it is a very good procedure that has shown to increase the oxygenation in patients. It improves the pulmonary gaseous exchange, and it diverts the blood away from the poorly aerated lungs to the aerated lung regions in the anterior thorax. This proning has helped us, and we have tried 16 to 18 hours of proning, and it needed a dedicated team. So since this is about mild pneumonia, proning response was from 90 to 97%. In moderate pneumonia, it was 88 to 94%. In severe pneumonia, the proning has helped from 70 to 85%. So this is invasive ventilation. Young patients, we gave a chance for intubation who had severe pneumonia, then family approval in elderly patients, and patients who were low GCS and unconscious, we had intubated them. But we have really seen good results in some of the patients, especially 3 patients from obstetric hospital who were COVID pneumonia with bilateral, they had Guillain-Barré syndrome, and we did cesarean in SMHS hospital only. And then after that, she was on intubated, then trachestomized, then she went home. So ARDS and invasive ventilation is a last resort. Patients admitted in ICUs are severe ARDS with PaO2 and FiO2 ratio less than 100, according to Berlin criteria. So invasive ventilations we have done, and we have followed the lung protective strategy like low tidal volumes and PEEP according to FiO2. So this is, we didn't have a good outcome after intubation in these patients, because I said that they were referred late to our hospitals. In SMHS, we lost 277 patients. In chest disease hospital, we lost 178 patients because again, there also, we got late referrals, and some of the patients had, they had renal transplant surgeries done. They had immunosuppressive diseases. They had liver transplant patients, and 3 of the patients were SLE, and most of the patients last year were above 80 years of age. So this is a chest disease hospital with high flow nasal oxygen, 90%, 90 survived, and deaths were 65 on non-invasive ventilation. In SMHS with high flow and NIV, the outcome was survival was 255 and deaths 127. And this is our outcome of both the ICUs with ventilation, intubation in these patients. You see the death rate is high, again, because late referrals. And how did we manage this pandemic? We had to rise to the occasion. We established 9 ICU beds of COVID, then 11 ICU beds in chest disease hospital and 7 HDU. And in obstetric hospital, we made an isolation area where we put in, we had 2 ICU beds for COVID patients, and we made an ICU, we made a COVID OT there so that we could do COVID patients there. And we have done more than 300 cesareans in COVID patients in last 1 year. So how did we go ahead? We equipped all of these ICUs with Hamilton C2 ventilators, Drager Savina ventilators. Then we got donation of Meditech and PM Care ventilators. Then we have a lot of high flow nasal cannulas in all the hospitals, portable NIVs. We made sure that all the ICUs have ultrasound machines. We have high-end multi-channel monitors. We have dialysis machines in all the ICUs. We have 25 ABG machines, eye stats, we have defibrillators, we have bronchoscopes, we have laryngoscopes, and all emergency drugs. And let me say that we have good amount of disposable items. We have air purifiers, we have HME filters and bacterial filters in all the hospitals. So how did we go for staffing? 3 to 4 doctors, and most of the doctors volunteered because they would feel attached to these patients, and they would say that we will go on repeating the duties, and we would manage the wards, ICUs by daily morning and evening rounds by faculty.
Professor Roxana, sorry to interrupt, we're really running short. I would be grateful if we could.
I'm winding up. Dedicated paramedical staff, then we have full protective PPEs and negative pressure rooms in chest disease hospital. So we rotate these duties of these doctors. Then we give government accommodation, food facility to doctors. Then we have special COVID allowance to these. We encourage every member of the healthcare service and their family members to get vaccinated. Then we manage some 2-3 outdoor recreations because we were feeling depressed and burnout. And all of us sometimes sit together and discuss very good things so that our mental health is intact. Then in the same time, we managed perioperative care of COVID patients, perioperative care of non-COVID patients, pain management and palliative was going side by side, anesthesia for ECT and psychiatry, then critical care of non-COVID patients. Then in ICU, we have non-COVID 8-bedded super specialty hospital. We have an SMHS 8-bedded non-COVID ICU. In addition to 2 COVID ICU, we have 4-bedded COVID beds in non-COVID beds in LD, and we have 2-bedded ICU in Bone and Joint Hospital. And at the same time, we managed non-operative room anesthesia like MRI, radiotherapy, cath lab. Then we managed trauma emergency services. And we have seen in last 1.5 years, we've got good amount of accidents and foreign body aspiration and a lot of poisoning and a lot of these suicidal cases. So how do we go? How did we go? We set up new ICUs and dedicated oxygen plants. We got 1,000 liters per minute of plants in ICUs of SMHS and CD hospital. Then we have backup of these manifolds everywhere, H-type. Then this was a liquid oxygen plants in our SMHS hospital. So future is procurement of additional ventilators, although we have a lot of them. We want to have additional technical and paramedical staff. Then we have recently started 125 COVID ICU bed, which was inaugurated on 9th of June this month. And we have 3 patients in our ICU and 20 patients in that 500 and 350 bedded medical ward. Then we are training doctors and paramedics in critical care and COVID. Then there is public awareness to avoid contamination, spread, and for vaccination and treatment. We go through internet, print, and digital. This was one of my programs. This is that. And this is how we take rounds in COVID ICUs. And what we have learned from the pandemic is that prevention is better than cure. We can't play God. Every patient is a new lesson each day, and constant effort leads to success. And we shall never forget the fallen, which we lost to this pandemic. Thank you.
Thank you very much, Dr. Roxana, and it was really a detailed presentation. I think you covered every aspect of the care that's being provided at Government Medical College Srinagar and its associated hospitals. We would probably have some questions regarding this, but I'll come to that later. I just want to get going with the panel discussion, and part of the panel will have. I actually looked at some of the things that you did say in that was really amazing, managing some complex patients. But let me get on with the panel. I'm going to share my screen, and we'll start with that. Can we? Yeah, I'm just stopping your screen share now. So can you see my presentation now? Can you see it?
Yes.
Yeah.
Yes,
okay.
yes.
Okay, thank you very much. And this was our primary topic. Much of it has already been covered by Steve. And now we are going to go a bit further in terms of technicalities and managing these patients. Just to begin with, what we think is a deteriorating COVID patients. And I had a discussion with Dr. Zulfikar last week, and he said that lots of patients would come as late presenters in a critical state. And I think you mentioned that as well, Dr. Ruxana. And I mean, we looked at from UK point of view, 80% of the patient population, COVID population is mild, but 20% require hospital admission. And of those 20%, about 20% are admitted to the ICUs, and 3% of those admitted require intubation, and 2 to 5% of those who are in ICUs die. Now, the point is you might have a different population to cater to, and you might be getting a different cohort of patients. My question, first of all, to Dr. Zulfikar here would be, I mean, you did tell me about that, and how would you recommend to the field doctors or field anesthetists or the hospital in other hospitals in the J&K or maybe in India or wherever people are from? What would you recommend them to look at the patients and how to assess their deterioration?
Yeah, sir. Basically, in the Indian scenario, there is a little bit a different situation what we have in USA. The peripheral hospitals, they are not so much well equipped as we have the tertiary care hospitals. So then there is a strong stigma attached to the disease, though now as the disease has become more frequent, there is a decreased stigma. What I feel is once our patients, they present to a peripheral healthcare center, if we have a patient who is having a mild to severe disease, sorry, a moderate to severe disease, he has to be referred to a tertiary healthcare center immediately. Admitting him in a peripheral health facility for a prolonged period may not be beneficial. If we are admitting him in a peripheral health facility, we have to keep a close watch on the disease progression. That's one thing. And second, what I would feel is important, many of the referrals that come from the periphery still now, when the pandemic has started to settle in Kashmir, we're still getting around 2-3 referrals for every day. Initially, we used to get 10, 12, which subsided to 6, now it's 2-3 referrals. But the spectrum of the referrals that we are getting right now, most of the patients, they're elderly one, they're having multiple comorbidities. So what I feel is the patients who are elderly with multiple comorbidities, they should be straight away shifted to a tertiary healthcare center. Once we keep them, they should be, once we keep them at a peripheral health center, the disease progression many a times progresses to a point where recovery becomes very difficult. These are some of the things that our physicians, they need to keep in mind at the peripheral health centers.
Thank you very much for that explanation and suggestion. I think Dr. Nasser Shams, who is
yes, he has raised his hand up. Yes,
he has raised a hand. So can you unmute and tell us your experience or a question if you want, Nasser?
Yeah, I'm basically working with my team at JLNM Hospital. Right from the start, right from the word go, we are working with our patients. But as Dr. Zulfikar already said, it was very difficult task for peripheral healthcare to come up with the expectations of COVID, though we had lesser of experience as compared to the tertiary care. But right from the word go, we tried to adjust to the new demands of the patient care, and even ICUs were started. The main problem what we faced with us was first we started with HFNOs, then we shifted to CPAPs, BiPAPs, but we know the number of equipment we had was less. We had more of HFNOs. And the issue of shifting our patient from ward to the ICU or HD facility was they desaturated fast and we could not even shift them from the beds. Second thing was, as Dr. Ruxana, I heard the presentation, was the issue of intubation arrest. As soon as our doctors tried to intubate and they started arrest. I would like anybody among the experts to just explain us about the process and how to go about, because this thing we have experienced a lot with us.
Okay, thank you. Can I come on that question? Yes. So I have heard that as well for the last 1 year. I think that comes down to how much of you at that point in time are aware of the internal physiology that's happening with regards to respiratory failure causing acidosis on top of the sepsis that's caused by COVID and metabolic acidosis, electrolyte derangement, and all of that together puts the patient into a very unstable state. And then at that point, taking the decision of intubating the patient means you are anesthetizing the patient, which is a very hard task in a very acidotic patient who has got a very arrhythmogenic heart. So if we have not addressed the issue of electrolytes, addressed the issue of acidosis, pre-intubation or pre-anesthetizing the patient, and if we do not have adequate facilities in terms of drugs, in terms of additional equipment, like placement of central lines, placement of arterial lines, I think it's going to be a situation where the arrests will be more commonly seen than otherwise. I think one of the reasons to mitigate that would be to take these decisions much earlier than at the point where you would have been taking them up to this point. That would be the only way to mitigate, or to be knowing exactly what is the metabolic, physiological, respiratory state of that patient at that point before you take that decision. That's my take on it. Having said that, I just put up this slide, as all of you know, some signs of failure. But what I would say, looking at the mental status of the patient would be quite important, because confusion is a good idea of hypoxia, acidosis, hypercarbia, as well as if there are any CVS changes, as you can see in the slide. Of course.
That's it. I would like to add here thoraco-abdominal paradox that could be helpful for physicians once we decide about the shifting of the patient. Shortness of breath, as you have mentioned, use of accessory muscles.
Can I comment? Can I comment for a brief moment? Yeah. Just the issue about we were discussing late referrals or late shifting to the ICUs. But the issue with us was the lesser amount of beds in the ICU, and the patients were actually waiting. And we had to sort of triage them, whom to, once the bed was vacant, and whom to take from the normal ward to this, because the patients were in line. It was not the decision we wanted certain patients. It was the overcrowded, it was the situation was such that we had one empty bed in ICU, and we had 10 patients in line who were getting sick and needed ICU care. So the delay was because of the presentation of the patients was such that we could not even shift because of shortage of beds.
I think I can fully understand your problems in Kashmir, because I'm not alien to that place, and but I can easily compare that with the situation in UK. When we get a patient, say, who has deteriorated in the periphery, the ambulance service have already done a lot of work on the patient by the time they come to hospital. But it's a different scenario, and you are overwhelmed, and we can especially we can appreciate all of that, and you know how difficult it was for you. But in all that, I would say you're doing a great job. I mean, it's not easy to be an intensivist or a respiratory physician or an anesthetist at this moment in time in Kashmir. Absolutely brilliant. Can I come to Umid? Umid, can I ask you a quick question on the same topic? While you were managing patients in critical care at SMHS, and obviously you were in contact with people from peripheries, would you give them some advice when they were transferring the patients to you?
Yes, first of all, we used to advise the doctors in the peripheries to sort of triage the patients, which sort of patients they could manage at their own end, and which sort of patients they could send over to our place. Ours is a final tertiary referral center of the state, including ours and the SCAMS hospital. So the maximum burden of the sickest patient was on us. We also were constrained by having only 8 to 10 beds in this SMHS hospital, and the rest of the wards were mostly the high dependency units. So what we actually wanted was that the mild to the moderate patients should have been managed at the in the peripheral hospitals only, and patients who were sick enough that they could not be treated at those places, we wanted them to be shifted to our hospital. The best that they could do at their level was provide big cylinders of oxygen and transport those patients from the ambulance to our center. That was the only thing they could do at that time, because we were having a dearth of transport ventilators also. And moreover, the peripheries are not so well equipped to handle critically sick patients, which actually need ICU admission.
Yeah.
So I think what we are missing here was that they didn't have the proper escalation protocols. They didn't know which sort of patients they need to keep at the peripheries and which sort of patients they need to transfer to our place. This webinar, I think, should actually address the issue of having proper protocols, escalation and de-escalation protocols.
Yeah, I think we'll come to that in a minute. Can everybody mute themselves, please, because we're having a background noise. Please mute everyone. Yeah, thank you. We will come to the escalation protocols, and I would want to add one brief statement before we move on to the next presentation. As a part of peripheral hospitals who are managing COVID, it's also important to understand that you are the first responders there in managing septic patients. So there are certain elements of managing initial sepsis, what's also called the golden hour, that you are addressing. You have got proper airway, breathing, circulation, and their mentation that you've looked into and addressed. Appropriate oxygenation, IV fluids, IV cannulas. I think if you think the patient is deteriorating immediately, I think the call should be early than late. With that, I would move on to the next presentation by Dr. Zulfikar Ali, who will probably discuss some escalation issues, and then we will move on to further discussion of the deteriorating patient in a minute. Dr. Zulfikar Ali, I'll just stop my share, and then you can start. Thank you.
Thank you, Dr. Yasir. I would like to thank the BKMA, Dr. Imtiaz, Dr. Yasir, for your excellent efforts in organizing this educational activity. It has been wonderful working with you guys over the last few months. You have been truly instrumental in helping us all the way in managing this epidemic. And I have loved the way you keep me on toes all the time, giving me short notices. Be ready, Zulfikar, for this. I will be just briefly discussing the respiratory care escalation for non-invasive positive pressure ventilation in COVID-19 disease. This is a small talk mainly aimed at our postgraduate students. COVID-19 patients, if we see, we have mainly where we have the problems. We have problems in managing their hypoxemia or hypercapnia. So if such patients, they do present us with hypoxemia, what should be our approach in managing the hypoxia in such patients? So if we see the acute hypoxemia in COVID-19 patients, we mainly define it as a saturation of less than 94%. And it may be associated with an increased work of breathing, which may be manifested mainly, as Dr. Yasir was pointing out, the accessory use of accessory muscles of respiration, nasal flaring, and the thoracic abdominal paradox. Mainly once we get mild disease, we manage them conservatively. And in moderate disease, we start with supplemental oxygen. So the initial step, we start with a nasal cannula of around 6 liters per minute. If our patient population improves, so we can continue the oxygen flow with nasal cannula. But if there is deterioration, high flow nasal cannula is the preferred option. Here, what I would like to emphasize that if the patient does not improve with nasal cannula, it's better to go to a high flow nasal cannula rather than using a non-rebreathing mask. There are multiple studies that have shown over the last 2 years that if we keep a patient who is not maintaining his saturation on nasal cannula and switch over to the non-rebreathing masks, the outcomes are not as good as once we shift directly to the high flow nasal cannula. Now, in many times in organized setups, we do have HFNC available. So if we have an HFNC available, what should be the approach we have to follow? Usually we start with inspired oxygen concentration of around 0.8. And if we have a transient emergency with a very severely hypoxic patient, we can start 100% FiO2. And we start with flows from 10 liters to 60 liters. But in resource constrained settings where we do not have HFNC, there we are compelled to use a non-rebreathing mask. And once we use non-rebreathing mask, it's presumed that once we use flows of around 10 to 15 liters, we do give the patient around 70 to 80% of FiO2. Now, in many settings in the Asian countries, because of ill development of infrastructure, we have to transfer the patients to the intensive care units. So what would be the safe time to transfer a patient to the intensive care unit? Or in other words, if we are having a patient who is stuck up in the periphery, we want to shift that patient to a tertiary care hospital with a better facilities. It's considered ideal by the World Health Organization that we should consider safe transfer at an FiO2 of 0.6% and a flow rate of around 50 liters per minute. It's not possible to transfer on an HFNC during transport because of the high consumption of oxygen. So it would be better to use the non-rebreathing mask in such a situation. Now we get many times various situations while once we are using HNFC, or if we do not have accessibility of HNFC,
Zulfi, we can't hear you, Zulfi.
Oh, okay.
a flow of around 10 to 15 liters. That's happening the rest.
I
His
think-
voice is breaking.
Yeah, I think we might have lost him in connection. What I'll do here is I will take over his presentation. I'll rather continue with my own presentation and continue with our panel discussion. So if I go back to my presentation now. So while we were talking about the signs of failure and we discussed some transfers, I just want to briefly touch the oxygen issue here. So in terms of oxygen, as we all know, it's a drug. It has to be prescribed. The key 4 things that everyone should write. Yeah. Oh, sorry. I thought we lost you. Are you back?
Yeah. Can you hear me? There was some problem with my connection.
Yeah, I just stopped my share. Can you put your presentation back on? Thank you. Sorry.
Can you just guide me where I lost contact?
I think we lost you on the 3rd or 4th slide. So if you put your presentation back on,
we probably discussed about this slide. Shall I move to this slide?
Yes. You have to share again. You have to share again.
Okay. Sorry. Is my screen visible now?
Yes, it is.
Yeah, sorry. I was just discussing that many times we do get scenarios where we have a patient who's persistently hypoxic once we are using a high flow nasal cannula or we are using a non-rebreathing mask. at very high flows. So in such a situation, there are many algorithms that have been in vogue across the world that have advocated the use of helmet continuous positive airway pressure, which may help to improve to decrease the mortality and the morbidity. And in such a situation, we start at high inspired oxygen concentrations and gradually reduce the oxygen concentrations. So again, we get many situations where the patient may be intolerant to the helmet mask. So in such a situation, as I was just asking our colleagues from United Kingdom, we do not use in, I think in many centers in India and in Kashmir, we are not exposed to the use of vasodilators, but there is a mention in the literature about the vasodilators as nitric oxide and inhaled ibuprostenol, which may be helpful in refractory hypoxemia. Intubation is another form of escalation therapy where we are unable to meet the oxygenation goal, where we have excessive work of breathing and a decreased level of consciousness. And in patients where there is significant desaturation, it's the last resort to help improve the oxygenation. And probably many of us, what we feel is that intubation is last end, and we do go for intubation at a very late stage. And I do not feel there are many trials, worldwide randomized control trials, that have compared the results with early versus late intubation. Once we intubate a patient, we have almost exhausted everything, and probably at the end of the day, we say that we couldn't wean off the ventilation. If we could go for early intubation, maybe the results could be better in such a scenario. Some of the adjuncts that have been helped to improve the oxygenation and could be incorporated in the escalation ladder are the prone positioning and again the use of inhaled vasodilators. And in our clinical practice, we are now getting patients who are free from COVID-19 disease. We are getting now an increased, my hospital is filled with around 30 to 40% of the patients who are RT-PCR negative. No active symptoms of COVID-19 disease, but over a period of 1 month, 2 months, we are not able to decrease their oxygen demand. They are having chronic hypoxemia. And this is becoming a difficult to manage patient in our spectrum, where we try everything. We rule out delayed cytokine storm. We treat the patient for pulmonary fibrosis, but many times it's a quite challenging task, and many a times we are not able to help the patient. What are the indications of non-invasive positive pressure ventilation in hypercapnia? For the benefit of our postgraduates, I have just summed all investigation in terms of the need for non-invasive positive pressure ventilation in terms of acute hypoxemia, or if we have a patient who is intolerant to HFNC, then we have acute hypercapnic respiratory failure, where we have a carbon dioxide of greater than 45 and a decreased pH. And again, we have acute or chronic hypercapnic respiratory failure. And then we have chronic hypercapnia and obstructive sleep apnea. And then in the COVID-19 disease, we have indications of non-invasive positive pressure ventilation. The COVID-19 disease is complicated with the consolidating pneumonias and the organizing pneumonias or superended infections. So as Steve wonderfully explained all this, I will just briefly skip. He has wonderfully explained us how we should approach our patient to the ventilation, as how we should fix up a ventilator in such a situation. Summarizing this flow chart, what should be our approach for the recommended oxygen escalation and use of non-positive pressure ventilation? So as we discussed, we use a nasal cannula up to 6 liters per minute in the initial stage. If our goals are met in terms of a decreased respiratory rate, low work of breathing, oxygen saturation improving, we can continue the oxygen via nasal cannula. And If our goals are not met, we titrate the oxygenation with high flow nasal cannula. And once we are using a high flow nasal cannula, when we are transporting a patient, we should use a non-rebreathing mask. If all goals are met, with an FiO2 of 60 to 80%, we can continue the therapy with high flow nasal oxygen therapy. But if our goals are not met, respiratory rate is still high, the work of breathing is increased, the patient is having acute hypercapnia with an increased carbon dioxide, decreased pH. We have to see if the etiology of the carbon dioxide increase is readily reversible. We have to rule out whether the patient is having COPD, narcotic overdosage, or congestive heart failure. If yes, we go for non-invasive positive pressure ventilation. If no, we have to think about the intubation. Again, if we have a patient where we are not managing all goals with FiO2 of 60 to 80% and saturation is less than 90%, we give a trial with helmet CPAP, we may get all our goals, the patient improves, there's settling of the respiratory rate, work of breathing, we can continue the helmet ventilation. But if goals are not met, we can again go for CPAP or BiPAP, or in extreme situations, again, try for the high flow nasal oxygen therapy. Thank you very much.
Thank you. Thank you very much, Dr. Zulfikar. That was very short, at a very short time interval when you prepared all this. I'm going to go back to my presentation, and then we have something more to talk about at this point, and hopefully there are people who might be interested in that bit. So, and we can continue with the panel. Can you see my presentation?
Yes.
So what I was mentioning is, as we are prescribing oxygen, and sorry, Dr. Zulfikar, we'll come to your points as well in a minute, because I have got some follow-up slides related to that. So as we are prescribing oxygen, we should make it a point that we do write on the prescription chart your oxygen targets, what oxygen device you want the oxygen to be delivered with, what flow rate do you want, because otherwise you do not deliver appropriate FiO2s, and what would be your starting FiO2. These four elements have to be written and followed through the oxygen therapy. In terms of conventional oxygen therapy.
Yasser, sorry to interrupt you, Yasser, there's a couple of hands up from Amir Khan and.
Yeah, shall I ask Amir to come in first, because he had raised hand, then we come to Nasser back.
Nasser, is your hand up again, or you forgot to bring it down?
No, he did bring it up again.
It's again.
Yeah, I was looking at him. But Amir, I did ask you a question on the chat, whether you wanted to ask a question, but he didn't respond back to me. So I'm not sure whether that hand was raised. Okay.
Can I come in?
Yeah, it is Nasser next. Yes, please do.
I'm based on the previous presentation last, I think during the presentation of Steve, I wanted to know what about sterilization of the equipment, HFNO, the tubings and all that. I think that was not taken. I want to know that we have the silicone tubes, we have the plastics, and that is not disposable with us. It is along with the equipment. Now the surge is down, we have the equipment, we want to sterilize and reuse it. How to go about it? I want to know from the experts, from the tertiary care and you people.
I think I'm not aware whether we do have an ethylene oxide facility in Kashmir that you could possibly use to re-sterilize the equipment. However, I'm not sure what other, you can't heat them or you can't use heating techniques. You could probably go back to the manufacturer because they're supplying the equipment to you. They should be providing you post-sales support and help with these things. And going back to my own times in SMHS, when I was in ICU, we used to use 2% glutaraldehyde Sidex. I don't know how good that was and how meticulous.
Yasser, if you allow me, there is a complete catalog by Fisher and Paykel on disinfection. So I can share with Dr. Nasser. It's very simple. There is a disinfection tube that has been attached and we have to open it. There are some videos and all that I can share with Dr. Nasir.
Sure.
And
Sure. Yeah.
it is doable.
That
It
will
is
be
not
awesome.
something which is not doable. And then at the same time, what I feel that we'll have to contact the suppliers for additional tubings. It's not something which is not doable now. We can get additional this tubing so that we have to resort to single use for a single patient.
Okay. Does that answer your question?
There's a comment from
Thank you.
Dr. Bashar also, and there's a question from Ali Imran, I think.
Yeah, Ali Imran, can you come
I
up
can
with
just share the document in the chat box also, so it can be helpful for everybody.
Yeah, thank you very much. Thank you, Dr. Zulfikar. Ali Imran, can you ask your question, please? You can unmute yourself and ask the question if you wanted to ask it here.
And there's also a comment.
Okay.
Yeah, carry on.
I have one question about use of, once we are using BiPAP machine or CPAP machine with a single circuit. So we use vented mask. So I have a question: how can we prevent transmission of infection to the healthcare workers? Because we have a vent in the mask from which expression will occur.
Yes.
So is there any method to prevent the spread of infection to the
recent studies have mentioned that these are not aerosol generating procedures, but in order to be cautious, can I ask you where are you working at the moment? Is it a peripheral hospital or is it a central hospital in Kashmir?
I am presently working at SKIMS.
You're working with SKIMS, so I guess
Yes.
you would have a good ventilation facility, I believe. So you shouldn't have huge issues with infection control, and you've got an infection control department which will be looking at it. But I would still say, can everybody mute themselves, please? Or is it, Imran, yours? So the thing is, you will have to be careful, take extra caution, but they are not as such aerosol generating procedures. Have the filters in place, have appropriate recycling procedures, as Nasir just posed up a question and we answered that. But beyond that, it is just to take all level 2 precautions. Otherwise, if you have any doubts.
Second, I have another question. Actually, it is regarding to use of HFNC.
Yeah.
We have seen some patients who cannot take orally, who are not able to feed themselves orally. So we need to put in Riley's tube. So if they are on HFNC, can we put a Riley's tube? And
yes,
if we can, does it affect the functioning of HFNC?
No, it does not affect the function of HFNC. We mentioned that, we discussed that earlier in the chat. Steve answered, I have already answered that in the chat. You can give them, you should feed all your patients, because if they become nutritionally weak, their sepsis will become worse, their immune system will become worse, and their pneumonia will become worse. So you should feed them. Can you mute yourself, Imran, please, while I'm answering that question? So please mute your, yeah, thank you. So the question is that you should feed them. You can put an Ryle's tube in, preferably a small bore if it's available. I think it's available in Kashmir, 8 French tubes. They are ideal. And you should also, if you have issues with gastric distension, then you can use prokinetics like erythromycin at a prokinetic dose, or which is I think 250 milligrams TDS, or you can use metoclopramide 10 milligrams TDS as prokinetic. These are the methods, and keep them upright position to prevent aspiration. These are the things that you can do, but you should feed them. You should feed all of these patients. Yeah.
Okay, I have a last question. I have a last question regarding use of NIV. I'm sorry to take your time.
No.
Regarding the use of NIV in purely acute hypoxemic respiratory failure, regarding the as a classic case of COVID, for example. So most of these patients they have purely type 1 respiratory failure. So they don't need BiPAP or NIV for that matter. They only need, most of them need CPAP only. So what actually happens is that we tend to use non-invasive ventilator. If patient is in ICU, residents tend to give pressure support on above PEEP. So what that does actually, that adds to the barotrauma, because patients already has very high ventilator demand. So on top of that, we are adding pressure support. So patients get large amount of tidal volume, which causes barotrauma. We have seen many patients in COVID areas in our ICU also. We have a non-COVID ICU, but we get post-COVID patients there who are on percent oxygen, who are having percent oxygen requirement. So we have seen many cases of barotrauma, pneumopericardium, mediastinal emphysema, pneumothorax. We have seen multiple patients. I think this thing needs to be highlighted, the use of NIV in a purely hypoxemic respiratory failure. For patients who are having type 2 respiratory failure like COPD, neuromuscular disorders, or any other obesity hyperventilation syndrome, for that we can use BiPAP. But for purely hypoxemic respiratory, why should we use NIV?
Yeah,
NIV in the kind of PSV or BiPAP. We should only use CPAP.
Yeah, you are right in saying that. Couple of things here. When you're talking about using these machines, they have high pressure alarms, which should prevent barotrauma. So you have to keep your alarms within the ranges that are safe for patients, number one. Number two, obviously, you have to titrate everything to the patients and be careful for all complications. Pneumopericardium sounds to be quite extreme, or pneumomediastinum, which needs to be looked into. You should be looking back at all those patients who have had those and see if they have had other conditions causing those issues. And if they have been coughing intermittently, have there been a lot of secretions which have increased the pressure, because those events can cause barotrauma. So you have to be careful, as we mentioned, to select proper patients. If they have got a lot of secretory load, then avoid and use alternative therapies. Just be cautious because of that. So I would say yes, but NIV is purely for acute hypercapnic respiratory failure, while a CPAP or HFNO is mainly for type 1 respiratory failure, which is being used in COVID at the moment. So going back to our presentation, when we talk about conventional oxygen therapy, we're talking about nasal cannula, simple face mask, and reservoir masks, which are shown in this presentation. And you see the flows, and you see how much oxygen you are actually delivering to the patients. Now, if I move on to the next part, what is an oxygen escalator? So it's an escalation policy that can be used, and probably you could think about, this is the British Thoracic Society / Intensive Care Society in UK, giving an idea about how to go about with oxygen escalation. Now, this does mention reservoir mask at 15 liter after your nasal cannula and simple face mask has failed. Just to be aware what Dr. Zulfikar said earlier, I'm just giving an alternative view. So if you have the ability to use high flow nasal oxygen, yes, you can go on to that. Otherwise, you can use reservoir mask. But taking into consideration both the things, what he said, what I'm saying here, I mean, you have the option of these things, but you have a list of Venturi masks here where you have exactly the FiO2 written. So that might help this slide in terms of what you will be escalating in terms of therapy. Now, going back to this British Thoracic Society guidelines, it does mention and gives you a flow chart of how to manage these patients when things are going wrong. Now, it does say saturation of 94% or less on room air. You should take that as 92% because that is what we are doing for COVID at the moment. But key thing is, yes, if the respiratory rate goes more than 30, that's the common factor which Dr. Zulfikar was saying. Look at the rest of the patient parameters, their GCS, how well they are doing on the saturation point of view. But the key indicator, which has been often proved in most of the COVID studies, have been the increasing use of oxygen or FiO2. So that is one of the key indicators of a deteriorating patient. So that will take you to another level at each point in the escalation therapy. And what I was thinking about was the ROX index, because it avoids doing the ABGs. Although now I can feel, while Dr. Ruxana did mention about lots of ABGs machines available as well as in SCIMS. So that's not a problem in SCIMS or SMHS, but I think that might be an issue in peripheral hospitals. So for that, you could use the ROX index, which is this. I have just put up a 2-hour ROX index here in this slide, which I have not put at 6-hour and 12-hour, which are different numbers. If you can work it out at 2 hours, that will be a huge indication of where you are going with your patient. So ROX index, as we mentioned earlier by Dr. Ruxana, SpO2 divided by FiO2 whole divided by respiratory rate. If you can work it out for each of your patients, you avoid doing the ABGs. I mean, I'm not saying avoid ABGs just because you can do ROX. I'm saying to those people who are in peripheries and can't do ABGs, they have got a reasonable idea. And recently there was a study. I can actually, if you do put up on the BKMA your on the survey that we have put on your emails, or send them your emails to me, I will forward you all these articles that are relevant. The ROX index has been known to have high sensitivity in checking the deteriorating patients in COVID. So it is really important, especially when you can't do ABGs. But in other words, otherwise you can use simply your ABGs and look at PaO2 by FiO2 ratios. And if they are less than 300, you start with HFNO, as we mentioned, or the respiratory rate is more than 30. And if that goes versus, I don't want to go into details of HFNO, but if you want to go on to CPAP, that means your PaO2 by FiO2 ratios come down to 200. Then you think about CPAP. These are all when you have got ABGs available. And beyond that, you go to NIV. When PaO2 FiO2 is less than 100, that means you're in ARDS category or severe ARDS category. NIV, if there is not hypercapnia and PaO2 FiO2 ratio is less than 100, you're closing in towards intubation. So this just is to give you more time to prepare for intubation, I guess, rather than anything else. I'll stop here because there's a question by Dr. Muhammad. Just says Dr. Muhammad.
Muhammad Sadiq, yeah.
Sadiq, oh yeah, yeah, Dr. Sadiq, I know you.
Assalamu alaikum, Yasir.
Alaikum salam.
It was a nice presentation by every one of you.
Thank you very much. Thank you.
But I have a simple query. Like in CPAP, we mentioned of C-flex,
yeah,
where inspiration phase ends and then you start expiration.
Yeah.
Okay. Similarly, in BiPAP, we have expiratory trigger sensitivity.
Yes.
We didn't discuss that expiratory trigger sensitivity. When should expiration start? What should be the timing, or how much flow should be there to start expiration? And in case of COVID patients, how it is important?
Yes. So shall I get on Dr. Zulfikar first to come? Are you with us, Dr. Zulfikar?
Yeah. Dr. Yasir, I'm with you.
Yes. So if we can address to this question, meanwhile, do you have any comments on this?
And Yasir, sorry, can you, Dr. Sadiq, repeat the question?
In a respiratory cycle, we have inspiration and expiration. And for expiration, we set some parameters like trigger for expiration. In case of CPAP, we have C-flex. While as in BiPAP, we set this expiratory trigger sensitivity. And that I see that it depends upon peak inspiratory flow. How much % of peak inspiratory flow should I keep so that patient starts expiration? And it becomes important once you are giving oxygen therapy to a patient of COVID, where you need to have inspiration for longer time than expiration so that his oxygenation will improve. So how much should be kept the expiratory trigger so that maximum inspiration occurs? And what is the normal setting for expiratory trigger?
Okay, fine. Usually in the expiratory trigger, we start at around 5 centimeters and we titrate it with the carbon dioxide levels. And the inspiratory trigger, usually you start with around 10 centimeters and we titrate it, we increase by 2 centimeters of water and adjust it so as to achieve an optimal oxygenation and an optimal carbon dioxide levels.
No, there is like we keep expiratory trigger like low, medium, and high. Or it depends upon
ramp. Basically, we have to adjust the respiratory rate. What we do is, if we want to, if we have a patient who is having a high respiratory rate, is in respiratory distress. What would be more important, I think, would be the ramp. We can decrease the time of the ramp so that the inspiration the breath is delivered mainly during the inspiration. So there is minimal asynchrony of the ventilator during the inspiration.
That is inspiration, but I want to prolong inspiration and start expiration a little later. So where should I put the expiratory trigger? Like I have read, it should be kept 25% of peak inspiratory flow. Do you have some idea regarding that?
I will have to go through it. I will have to go through it.
Can I
Yeah,
come into it?
Yeah,
So,
yeah.
The thing I would suggest is, first of all, when we talk about COVID and you're talking NIV triggers, what you have to understand is how far you are into your respiratory physiology, where you are in terms of acidosis, which is contributed by the respiratory system or hypercapnia. And if you are treating NIV in patients who are already previously known to be hypercapnic, like COPD patients, then their parameters would be different. Their respiratory physiology would be different. They would be more, tolerant of acidosis because they've got high bicarbonate levels. But this is a purely ventilation question. When you asked about where will you set up the trigger for expiration, I would say it has to be balanced between their hypercapnia and between how much of oxygenation you need. The problem with this is, are you doing NIV in acute hypoxemic failure only, or are you doing this in acute hypercapnic failure? In COVID, we see mainly hypoxemic type 1 respiratory failure. And if you look at the COPD patients, they do form a small cohort of, or a good cohort of COVID patients. In those, it might be even more complex to set up these numbers. I do not have a clear answer personally to this because I don't use NIV, so I'm not sure. That's why I passed the question on to Dr. Zulfikar. But I think we'll have to look into it, and this is a valid question which needs to be addressed if this was not a sufficient answer.
Okay.
And I'm just conscious of that's getting a dinner time in Kashmir, so we
we will be hopefully finishing soon. I think, is that Dr. Ali Imran asking any more questions?
I am Dr. Imran from SKIMS.
Yeah.
I actually want to add to this expiratory trigger question, which was said by, I think, Dr. Sadiq.
Yes.
So in an ICU ventilator, once we are using pressure support ventilation, we have one setting up that is expiratory sensitivity, which Dr. Sadiq actually asked. Expiratory trigger.
Yeah.
So basically, as a default, we set it at around 25 to 30%. That is, once the peak inspiratory flow will drop to 30% of peak inspiratory pressure, at that time cycling will occur. That is, inspiration will change from inspiration to expiration. So as a default, we set it as 20 to 30% or 25 to 30. But in the context of patients who are obstructive airway disease like COPD or bronchial asthma, we set it at a higher level, like 40%, 50%, 60%. So that the idea is that we want to increase the expiratory time in a patient who is having obstructive airway disease. So we tend to set it to 40, 50, 60% and see the patient's response. While in case of a COVID patient or patient who has restrictive lung disease like ILD or ARDS or severe COVID pneumonia, we will tend to set it to less than maybe 20% or 15%. So that more time, because of very less time constants, we have to give short inspiratory time. While as we have to set
short inspiratory time should remain result.
Amir, you are talking vice versa. Once you keep the trigger 25% of peak inspiratory flow, it means the expiration will start very immediately.
I am completing. I am completing. I am completing.
Vice versa.
No, I am not talking vice. I will let. See, I told you once patient has obstructive airway disease, we will set it at higher side. Why? Because
in a sensitivity higher
side,
the value low. Higher sensitivity means
you listen. You listen to me first. I will complete.
Can I please come in? Can I please come in?
Yeah, as I told you, I am not talking vice versa.
Imran,
25 to 30% is the normal standard level. If patient has obstructive airway disease, we will keep it to 50%, 60% or 70%. By that, what will happen? Inspiration will end early and we will have more time for expiration in the case of COPD. While as in case of ARDS or COVID, we set it on lower side, like 15%, 20%. That was my point initially, and same I am saying same again.
Can I come in, please? I think
Yes, yes.
this is diverging from the main discussion, but this is a valid question. And when we do mechanical ventilation in ICU patients who are sedated, things go probably all channelized into ventilation, and you're looking at low tidal volume ventilation, pressure support ventilation, or pressure controlled volume guarantee modes. Going into very fine intricacies is okay, but generally we have not been doing lots of intricacies here as much as you guys are thinking. I think the point is to look at the patient in general, look at their physiology, look at where you are headed rather than going to deepest points of how there are about 100 ventilation modes, and each ventilator company comes up with a new mode. But the key modes are pressure control, volume control. There are some finer points that we need to address, but do not go into too much details of discussions about modes and sensitivities. You have to look at the deteriorating patient in total as well.
Yasser, may I suggest that we take the question on board and come back with the right response? So, good question, and we'll be more than give some time, and we'll come back to you with the proper response.
Yeah. So moving on with some other things that when we talk about, sorry, I'm just losing my chat. Yeah, sorry. So we're taking about failure of non-invasive respiratory strategies. This is probably very important considering that people who are in peripheries or who are in tertiary care centers, they should look at, first of all, starting from A, B, C, D, E, full patient head to toe examination, but importantly, looking at the heart rate, acidosis, oxygenation, respiratory rate, tidal volumes, and then of course the PaO2 by FiO2 ratios or ROX index, what has been suggested might be a good one in terms of COVID. I think overall, you guys are doing a great job, and peripheries are really stretched in terms of what I think Nasser was telling me. We need to go ahead and go into the future working hard in terms of finding strategies that will be easier and more compatible with Kashmir at each level. We cannot fit a strategy from SMHS or SKIMS into a district hospital in Baramulla. So we have to find a district hospital strategy and a tertiary care level strategy. I would, is that what you would recommend, Umeed, as well? And I would give
exactly.
Previous question I just did. Meanwhile, I just did some brief search. What we see the default values are for all ventilators, they are around 25% of the peak flow. And then once we have patients with COPD, they are prone to late cycling. So there we go for an initial ETS setting is around 25% for patients with normal mechanics and 10% for patients with restrictive mechanics. So in COVID, the literature has to be explored, and I think we will do some research on it so as to, once we put these patients on this ventilation, so as to find a proper trigger.
Yeah, okay, fine.
So Yasser,
Umeed, yes.
The whole discussion has been quite fruitful for all of us, but the thing that's most important is that this place is constrained for a lot of things, for equipment, for doctors, and for the amount of care that we can provide to the patients. What we exactly need for our place is a triad system of which type of patients to segregate, right? So because the peripheral hospitals, they are still gearing up. They're still gearing up to provide adequate care. We are also constrained because we've got a limited number of ventilators, limited number of HFNCs and CPAP and BiPAP machines, all right? So what are the other methods? Like, for example, can you advise us something about how to recruit lungs in an awake patient? What are the other ways of,
You can't do much in awake patients. Recruitment maneuvers you do mainly in, but you can ask them to do some respiratory exercises to recruit, and we'll like keep them upright. Or sometimes if it's selective patients, you do awake proning to recruit more areas.
I think we should concentrate, considering our resource and all that, we should concentrate more on these things, the aspects of proning. I think proning helps a lot of patients. Moreover, the pathophysiology of how COVID affects the lungs, because there are some the less responders and the high responders. So the strategies, the individualized strategies for people also are different in different patients. So that's what the importance of this topic to decide more on the non-invasive and HFNO.
in terms of going forward, in terms of COVID, we know it has more peripheral, it damages the lungs more peripherally, as the CTs show quite often. Again, we had to do selective proning, etc., etc. Going forward, I think it'll be nice to develop a forum where we can explore plans for peripheral hospitals and tertiary care centers. I had tried to get in touch with people. I hope I can manage to get in touch with them again and try to, we could form a WhatsApp group or something so that we could establish plans, so that we could formulate, okay, this is the plan for district hospitals and this is the plan when you should trigger a contact with the tertiary hospital. And then in tertiary hospitals, we obviously, we have experts here, Dr. Zulfikar and his team in SKIMS. Professor Ruxana is with us. I will give her, I hope she's here, and I just wanted to ask her one last question. And yeah, thank you. And these are the people who could actually move the whole system forwards. We know our constraints, we know our problems, but we are the ones who can find solutions. I would like to have a lot of district hospital people. Yeah, please do. I didn't want to ask this question.
I think we have done an excellent job. Our mortality was only 1.1 over last 1.5 years as compared to UK mortality of 3.6. So we have expanded our departments, and sometimes we have taken patients on trolleys in CD hospital and in super specialty and in ward 10 and so many ICUs. We never thought that we would not give treatment to these patients. Sometimes we had to convert non-COVID ICUs into COVID ICUs, like we had complications of Guillain-Barré syndrome. Then we had patients of pneumothorax who were COVID positive. We shifted them to the COVID positive, to non-COVID wards and isolated them. We never, not gave treatment to patients. We operated so many patients of mucormycosis who, although were non-COVID, but basically they had COVID complications. So I think we have done our best, but we still need to improve. And we have got 70 technicians in last 1.5 in just 1 year. So those technicians, they went out of their way to help the patients. They could attach to these patients and helped us in every way around. And we have 7 HDU beds in CD hospital, and they are managing those patients and they refer the patients at a proper time. So that's why we see very good outcome these days in CD hospital ICU. Out of 11 beds, we see every day, every second, third day, 3-4 patients are getting discharged from our ICUs of CD hospital. But our outcome is not that good in just in SMHs, because this is a referral for so many medical colleges. Every day I get calls from so many medical colleges for referral to this. And we don't deny the bed. We put them on trolley and then next day they get a bed in the waiting. So I think we should be very happy with what we have done, and the instruments and the ventilators and ABG machines and ultrasounds. We got new ultrasounds, we got high-end machines, everything. So I think overall, we are very, very happy with what we are doing.
Absolutely. I mean, the amount of work you've done
mortality was only 1.1%.
I mean, looking at patients, I was really...
I have video recording of so many patients where my doctors told me, ma'am, we may lose this patient in 2 or 3 days, but they went walking from the ICU, and we are so happy about it. We had 2 dental surgeons who, on the very first day, we told them, if you want to live, go for proning for 16 to 18 hours. And she was so cooperative that after 12 days, she went home after proning. So educated patients behaved very well with us. So overall, I'm very, very happy with what we have done.
No, thank you very much.
From 7 ICU beds, Dr. Yasir, we have 45 ICU beds in a span of 1 year.
I worked there when there were only 6 ICU beds in total, only 3 ventilators.
Now we have 40,
you've gone from Puritan Bennett 7200, which we were using.
We are using Hamilton C2, C5, G5. So we are not happy with the ventilators that we have got this time.
I think it's an amazing work that you're doing, but we can definitely, there is so much room to improve.
Special thanks to the faculty, to residents, to the paramedics who helped us out. They were all there to help the patients.
Yeah, thank you so much. I think I think going forwards, I think I'll try, and I'm sure Dr. Imtiaz has been so keen, and I mean, to be honest, he's the engine of this whole thing. I think going forward, we might try to formulate a group and run. I think I know I have some friends, and with Dr. Zulfikar and Skims, who is a amazing,
You're on mute, Yasser. Yasser, please unmute.
Yeah, sorry. I got muted for some reason. So with people like Dr. Zulfikar and Skims, who has been really patronizing us in terms of, he's very keen to improve the system there. And I have observed that in this forum today, we've got really exciting and really amazing people in Skims, residents. I'm not sure what level they are, but they were participating in the discussion. We have some very, very important people in the peripheries. Nasir really contributed good, and I'm sure they're doing amazing work there. I think we're going forwards, we will try to build up a forum and try to find solutions and protocols. If we can tweak things and get the referrals in proper place, maybe that'll help saving more lives and decreasing the amount of pressure that you are facing in tertiary care centers. But in totality of this, I think I would end this discussion by saying that everyone has been amazing in Kashmir. And despite the constraints, I may say lots of things that I do, but that doesn't work with the amount of pressure you have. It has been an amazing effort. And thanks to you all for being here today. This shows the enthusiasm of us all working collectively for a single aim. I would pass on to Dr. Imtiaz Gilani to end this session. It was personally, I thought it was an amazing interaction. If anybody has any questions, there is my email on the COVID flyer that we have sent. Please do communicate. I'm more than happy to set up a forum on WhatsApp, which is probably very quick to interact, so that as anesthetists, intensive care physicians, respiratory physicians, we could build up a forum and work on that. Thank you very much.
Dr. Yasser, can I come in?
Yes, please.
Dr. Yasser, the issues which really bothered us during last 1 year was the paramedics and the doctors getting positive, COVID positive. And we saw that most of our faculty and most of our the paramedics and doctors, they got positive in non-COVID areas because there they were not taking proper precautions. And we saw less number of doctors who were in COVID areas. They were not getting positive except if they had exposure at home. So this means that we were using proper protocols, SOPs in our COVID ICUs. So this time also a few of the doctors who are positive, that would give us tense moments. Who will go for the duties? How do we arrange the duties? How do we arrange the paramedics? And 70% of our paramedical staff is on ad hoc basis. So they were, once we started ICUs, they were saying that, please take care of our families because we don't have a permanent job if something goes wrong. They thought that while going to an ICU of a COVID area, they may lose their life. So many issues which we had to manage over the year. Yes. Now we are used to it. We know if you have a COVID positive patient, he is injured, he has head injury and RAT is positive. We go for surgery, isolate him for some time and then fumigate that area. And we have been very prompt in fumigating our ICUs. We are asking principal to lend us her critical care unit of coronary area so that we go on regularly fumigating our wards. So that has also helped us a lot. And then the support from the administration. And I should thank my faculty, my residents, and paramedics and nursing staff for outrightly supporting us and helping these patients. So that's why we are happy and satisfied today that we have done something for the community. Thank you so much.
Thank you very much. Dr. Imtiaz, I think Nasir just wants to put in a last word before we pass it on to you. You need to unmute yourself, Nasir. You're muted.
I want to thank you all, Yasser, Imtiaz, the British Forum, who is helping us, acting like a big dad behind us. It's great motivation and support. And I would like to highlight that our JLNM people have really contributed excellent support. They have been They have been right from day one. With a very less staff strength we have been able to manage the critical areas very well. I thank them. I thank you. I thank whole forum who has been there for help. Thank you very much.
Thank you,
Thank you,
Nasser.
Doctor.
I think I won't take too long because I know it's dinner time, but time was. So very quickly, I will say, what this pandemic has taught us also is not only medicine, also about humility, to also learn from our patients. Each day I walk into my department, my patients humble me in every fashion. And we made mistakes, we screwed up, we made so many misdiagnoses.
Yeah.
The time when we put patients pneumothorax in the COVID zones because they were short of breath, with patients with pulmonary METs, canal METs who were wrongly triaged to the wrong areas. And we learned in wave one. And one of the things I learned is if you have a culture of learning and where there's no finger pointing and the whole emphasis on education and being open and honest about when things don't go right, that's a culture which we should inculcate and try and encourage, because medicine is nobody's bigger than the game. Medicine is what humbles us, and nobody's an expert. We all have to learn from each other, and nobody's big enough to know everything. Steve is my nurse, and honestly I didn't know about doing NI for the last 15 years. I hadn't thought about rise times and so forth, even AVAPs, he taught me. So, and it makes such a huge difference to my patients. So, so we all students ultimately, and we learn from each other, and please learn from our mistakes. We absolutely screwed up in wave one. I can't tell you how hard it was. And also on a personal front, I had COVID, my wife had COVID, my 2 kids had COVID, my in-laws, and 3 of my very close relatives had extremely severe COVID, and was it not for the great care they received at SMHS, JVC, and SKIMS, they would probably not have made it. So a big thank you to all of you for looking after my flesh and blood, and God bless you all. And I have nothing but huge gratitude for all of you. With this, and once again, my huge thanks to Professor Roxana, the panel members, Dr. Umid, Yasser, Dr. Zulfikar, and also huge thanks to the Director of Health, Dr. Mushtaq Rathar, and Dr. Manzoor Qadri. I will not forget his huge thanks for what he did to make this happen. To Nasser, Saeed Arif at JLNM, and everybody else who was part of the journey with us. So may Allah keep you safe and bless all of you. And please do keep teaching us, and we learn from each other. And with this, I will call this. Yeah. So yes.
One last slide. We do not want to forget Dr. Zarqa Batul, who has been behind the scenes running the show. Sorry.
Zarqa is
Thank you so much. Thank you.
Imtiaz.
Yeah.
Imtiaz, what happened at JLNM? JLNM physicians came in, then dermatologists came in, then CVTS surgeons came in, then lab surgeons came in. All the experts from specialties other than medicine have been pulled in and have worked for the last 1.5 years and tackled these 2 waves so brilliantly that I'm really humbled. They have taught us. We being physicians, I've been daily helped and taught by the colleague dermatologist, who has handled nothing else for the last 1.5 years except COVID. My surgeon. So everybody has been of such a great help, and the best teacher has been our patient, who has been so calm, has helped us to correct the mistakes, and has given the window to work on a better patient care. So thanks to them, and thanks to the support which we have tried to manage over the last 1.5.
On that
one last thing I want to say, Nasir, although we are almost half a distance away in the globe, 8,000 kilometers from you, but our heart and our soul beats for you, and we want to help in every way we can. Please tell us what to do. We are here for you. Thank you.
Thank you. And with this,
thank you very much. Thank
you. To close, and God bless you all, and may you be safe.
Thank you.
Thank you. Assalamu alaikum.
Thank you.